Morning, good afternoon, good evening, and welcome everyone to this seminar. Thank you very much for attending this seminar. On behalf of Research Center for Preclinical and Clinical Medicine, I would like to extend a warm welcome to all of you for taking the time to attend this event. As we all know, non-communicable diseases have become a serious health problem. An increase in morbidity, complication, and mortality that they cause requires serious and comprehensive treatment. Non-communicable diseases, including heart disease, stroke, cancer, diabetes, and chronic lung diseases, are collectively responsible for 74% of all deaths worldwide. More than three-quarters of all NCD deaths and 86% of the 17 million people who died prematurely or before reaching 70 years of age occur in low and middle-income countries. The epidemic of NCDs poses devastating health consequences for individuals, families, and communities, and threatens to overwhelm health systems. The socioeconomic costs associated with NCDs make the prevention and control of these diseases a major development imperative for the 21st century. Based on this consideration, we present an effort to gain a deeper understanding of non-communicable disease through this webinar, which specifically raise the theme of role of molecular testing and prediction modeling in diagnosing and treating non-communicable diseases. On this occasion, I would like to express our gratitude to the speakers who have been willing to share their knowledge in this webinar. We are truly fortunate to have enlightenment from a very competent resource person here who have taken part internationally. Together, they bring a wealth of knowledge and experience on the molecular testing and prediction modeling on NCD to this seminar. And I am certain that their insights will be nothing short of brilliant. There is Ibu Ivo Sahbandar, MD, PhD. She is an adjunct assistant professor, Iwate Medical University School of Medicine. Next, we also have Bu Eva Swartana, MD, PhD. She is my childhood friend, who is an adjunct professor at McGill University. And we have also Pa Anthony, MD, PhD from the UNSW. Their unique perspective, I think, on this topic will be truly valuable for all of us. Last but not least, I would also like to introduce our dear friend, a researcher at the Research Center for Preclinical and Clinical Medicine, Ibu Yuyun Yuniar, who is pursuing a doctoral education in UNSW as a moderator at this event. On this occasion, I would like also to take a moment to express our immense gratitude to the organizers who have made this seminar possible. Without their support, we would not be here today. We are truly thankful for their efforts and contributions towards this event. I hope you all will enjoy and benefit from presentation and discussion with our distinguished speakers. Please enjoy this seminar. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Dr. Harimat, for the remarks. Ladies and gentlemen, before we start the agenda, we will have a photo session first. To all participants, please activate your camera. And for the committee to take the screenshot. I will start count from first slide. Okay, ready? 1, 2, 3. Second slide. 1, 2, 3. And third slide. 1, 2, 3. Thank you. Now we are going to start our discussion for today, which will be led by Yuyun Yuniar SSI Apoteker MA. Before that, I will read her CV first. Yuyun Yuniar SSI Apoteker MA. She is a professional physician in researcher at Research Center for Medical and Clinical Medicine Research Organization for Health, National Research and Innovation Agency Indonesia from 2022 until now. In 2005 until 2022, she is a researcher and head of section of pharmaceutical and medical devices, Center for Research and Development of Health Resources and Services, National Institute of Health Research and Development, Ministry of Health. Her educational background: PhD candidate at University of New South Wales, MA in Health Social Science, Mahidol University, Thailand from 2008 until 2010. Pharmacist program at Bandung Institute of Technology from 22 until 23. PSc in Pharmacy, Bandung Institute of Technology in 1997 until 2001. Selected publication, Panda et al. 2024, the availability of essential medicine in primary health centers in Indonesia, the Lancet Regional Health Southeast Asia, Despiteri et al. 2023, Job Satisfaction Model of Primary Healthcare Midwives, Kesmas, Jurnal Kesehatan Masyarakat Nasional. Okay, to Mrs. Yud, time is yours.
Thank you, Mbak Andalusi. Okay, good morning, good afternoon, good evening, and good night. Since I believe that we are currently in different time zones, so I consider that this is a real international seminar. I would check my voice. Is it audible?
Yes, please.
Okay. Okay, thank you. Okay, welcome to our seminar today, which will raise the topic on the role of molecular testing and prediction modeling in diagnosing and treating non-communicable diseases. As has been mentioned by Mbak Andalusi, my name is Yuyun, and I am honored to be your moderator today. We have an exciting lineup of speakers who will share their insights and expertise in their field. I think one speaker already joined us, Dr. Ivo. I already saw her in the participant, and maybe the other. Okay, yeah. Dr. Ivo is already joined us, and maybe Dr. Eva will join us later, and Dr. Anthony might join us in the afternoon. Before we begin, I would like to go over some housekeeping items. First, please ensure your microphones are mute to avoid any background noise. And we encourage you to use the chat box for any questions or comments during the presentation. There will be a Q&A session after each presentation where you can ask your questions. And I saw that currently we have around 80 participants, including us, I and Dr. Ivo, of course, is joining our seminar today. So I made a pantun. I aim to make it in English, but unfortunately, it's kind of hard to do pantun in English. So I made it in Bahasa Indonesia. Please prepare your cakep. You can unmute yourself. Okay. Burung dara terbang ke tempat gelap.
Cakep.
Burung angsa main di balik semak.
Cakep.
Pembicara nampaknya sudah siap.
Cakep.
Para pemirsa diharapkan menyimak. Oke.
Siap.
Baik. Yes, of course. Okay, let's get started by introducing our first speaker, Ivo Ensah Bandar, MD, PhD, who will be speaking on us on the role of molecular testing in cancer diagnosis and therapy. Dr. Ivo is currently a resident in anatomy and clinical pathology, New York Presbyterian Weill Cornell Medical Center in USA, and also an incoming fellowship in hematopathology, New York Presbyterian, in the same institution. She gained her medical doctor in the University of Indonesia in 1994 to 1998, and Doctor of Medicines in the University of Indonesia, and also another Doctor of Philosophy from Iwate Medical University. And this is the selected publication, Detectable monocyte HIV RNA pre-antiretroviral treatment curtail post-treatment cognitive improvement in acute HIV infection. So this is still in the preparation stage. And another one is primary effusion lymphoma in an HIV negative patient with chronic myeloid leukemia treated with dasatinib. So please join me in welcoming Dr. Ivo. Okay. Dr. Ivo, what time is it now in New York?
Thank you. It's almost 9 p.m. in New York.
Okay, so it's already night. It's in night, and I think it is summer in New York, right?
Yes, it's summer.
Okay,
So we still
because
have light outside.
yeah, but for me, it's like this is because we are in different hemispheres. So you are in the northern part, and
The
I'm in the
opposite,
southern
yeah.
part. Yeah, so I'm in winter. So I think we need the proper. Okay, you have 40 minutes to present. You can start, and time is yours.
First, thank you, BRIN, for inviting me to speak in this event, and also for all the participants. I know it's pretty early in Indonesia. At 7:30 studying is pretty early for me. So it's amazing that everyone, that's over 80 people, is here. So I truly appreciate everyone who make time. Let me share my slide. Sorry. Can't open my slide, sorry. Do you see my slide?
No, not yet.
Oh.
Okay, wait. Oh.
Let me try again.
Yeah, it's coming.
Okay, do you
Yes.
see the slide?
Great.
Okay, perfect.
Yeah, great.
Okay, so I just want to make sure that you are looking at the slideshow, right? The slide view.
Yes.
Okay, so
Yes.
my talk today is titled "The Role of Molecular Testing in Cancer Diagnosis and Therapy." And I'd like to do this talk as a not too formal. I will have a lot of anecdotes and stories and the clinical cases to bring my points about the role of molecular testing in cancer diagnosis. I know that we have the Q&A session later, but if you have any question, please feel free to stop me. And if you want to have any ask me any question, you are more than welcome to do so. And this is my disclaimer. I do not have no disclosure, and all my opinion are my own. And in Indonesian, we always say "tak kenal maka tak sayang." So I always start my presentation with introducing myself. My name is Ivo. I started my career as a physician. I was an internal medicine specialist. I work in Jakarta. And after I finished my training in internal medicine, I decided that I wanted to do research. So I went to Japan and I worked for a while as a researcher, both in Japan until I relocated to the United States, and I worked as a researcher at first at the University of Hawaii until I relocated to New York. And for about 1.5 years, I worked as a researcher at Weill Cornell Medicine in New York City. Until I decided that I miss medicine, so I decided to go back to being a doctor, to being a physician, and that's when I joined as a resident physician at the New York Presbyterian Hospital, Weill Cornell Medical Center in New York. Okay, so this is what we are going to discuss today. We're going to talk about the molecular testing in cancer management. What are the essence of this? Molecular testing technicality. I'm not going to talk too much about the technicality because I am sure everyone is very familiar with the assay and technique to test for the molecular testings. I also want to talk about the molecular application in cancer diagnosis, and not just the cancer diagnosis and treatment, but also molecular application in cancer prognosis, and why should we care about prognosis. I will talk a little bit about the downside of all of these tests and the summary. Okay, so let's start with the molecular testing, the essence. So I'm going to talk a little bit long, and I'm going to stay in this slide for a little long, because this is the essence. This is very important in molecular diagnostic in oncology. So we have 4 main reasons why we test for molecular. The most common one is hereditary cancer syndromes, and I'm sure everyone knows this. We can utilize PCR, sequencing, both Sanger sequencing, next generation sequencing, or whole exome sequencing. And this is usually aimed towards the cancer patients. The patients who already have cancers. And why are we still testing for molecular is because we want to know if this patient have a secondary malignancy. For example, I'm sure you're all familiar with the BRCA2 mutation. The famous actress Angelina Jolie, I'm sure you're familiar with that, with her, was tested positive for BRCA mutation. And we don't just test for BRCA mutation. Usually it was triggered either by a cancer in the patient itself or a cancer in the family. For a cancer patient, for example, someone who has breast cancer, we test for BRCA positive, for BRCA mutation. And if this patient have a positive BRCA mutation, we will explain to the patient that not only that they have breast cancer, but it's also increasing the risk for another cancer, for example, ovarian cancer. So in these patients with a family history, with the history of breast cancer, we usually explain the risk of developing a secondary cancer of the ovarian cancer to this patient, and we can even offer these patients to have their ovaries removed to prevent the ovarian cancer to happen to this patient. The hereditary cancer testing, molecular testing, we also do it to the healthy people. For example, again, let's say you have a family who have a breast cancer in such a young age, and then they have a BRCA mutation. Perhaps it's a good idea for another female family member to have the BRCA mutation tested. So if they are tested positive for BRCA mutation, then we can suggest the patient to have earlier screening for breast cancer, earlier mammography, or a more frequent mammography. Instead of once a year, for example, we can offer them to do it every 6 months. The molecular diagnostics we also use for predictive markers. So in the predictive markers, we utilize the similar assay to the hereditary cancer syndromes, but in the predictive markers, we target, it's a more targeted assay. So for example, we tested HER2. This is for the breast cancer patients. We test if they have a HER2 mutation. If they do, we will treat the patient differently than the patient who does not have any HER2 mutation. EGRF mutation and BRAF mutation in thyroid and lung cancer patients. Again, if these patients are tested positive for this, this is going to change the course of the treatment for the patients. And also the tumor phenotypes. For example, for patients with colon carcinoma, they might have the MSI mutation, and this can also change the course of the treatment for this patient if they have an MSI, because the MSI is famous for causing a syndrome that we call Lynch syndrome. So once we identify that the patient have Lynch syndrome, we might have to screen the patient for other cancers in the body, in the patient's body. The third aim for the molecular diagnosis is also for the circulating tumor fragments. So what we do, this is a relatively new field. So what we do is we do the assay, for example, a cell-free DNA assay to basically control the tumor eradication, both in the patient that has been treated with the traditional or the more common chemotherapy, or to also help us choose the mode of therapy, like what is the best therapy for the patient. And this is still in the future. I don't believe that the early diagnosis for healthy people is already, we don't have yet the molecular test for this. But this is used for to diagnose the patients early by testing the blood and testing the circulating tumor in the body, in the patient's body. But unfortunately, this is still in the research stage. And last but not least, we use the molecular diagnostic for the carcinomas of unknown primary. So what is carcinoma of unknown primary? In pathology, I don't know like how many of you are pathologists or familiar with the field of pathology, but in pathology, while most of the time we can diagnose the cancer from the biopsy or from the morphology or from the immunohistochemistry, but there are times when we cannot determine like where does this cancer come from. Like for example, the patient have a lymph node, an enlarged lymph node, and we biopsy the lymph node and it's a cancer, it's a carcinoma. So we know because lymph node cancers are lymphoma. So if we find a carcinoma in the lymph node, we know that it's a metastasis. And sometimes the patient, the cancer itself is so poorly differentiated. It doesn't look like the origin of cells of the cancer itself. It's so hard to determine like where does this cancer come from. So molecular testing is one of the tools that we use often in pathology, where we can test this metastasis and determine like where does this cancer come from. Oftentimes, for example, it comes from a skin cancer that's so small, the primary cancer is so small that we can't even detect it, but it's already metastasized. With molecular testing, it can help us determine like, oh, it's a melanoma, it's a skin cancer. So we will be able to treat the patient the way we treat a patient with skin cancer. So molecular testing is also widely used in precision medicine. So what is precision medicine? Precision medicine is used when conventional medicine fails. So conventional medicine is the cancer treatment that we use for most people. So it's kind of like a cookie cutter way of treating cancer. For example, if you have lymphoma, you start with CHOP treatment, chemotherapy. Sometimes if you have a bone cancer, sometimes you start with radiotherapy. But these are the standard treatment for any cancer, for any people. Most of the time it works, but sometimes we have those patients who doesn't respond to this treatment. And this is when the precision medicine plays a role. So in precision medicine, we investigate the cancer cells and the cancer itself more holistic or more comprehensively, so that we can create a tailored medicine or a tailored treatment special for this patient. And again, this only we only do this for the patient that has failure to the traditional treatment. the precision medicine and the molecular testing has also changed the paradigm on how we diagnose cancer. So, for example, in this presentation, I'm going to talk a lot about lung cancer because this is one of the cancer that has been having a lot of development when it comes to treatment because of the molecular. So when I was a medical student in Indonesia, long time ago, the diagnosis of lung cancer at that time was just non-small cell lung cancer and small cell lung cancer. That's it. It was easier for us to diagnose, but it was bad news for the patient because there's not a lot of variation of treatment. And then, so after 2000, the year of, after we find that the lung cancer have a various type of histology, we start dividing the cancer into squamous cell carcinoma and adenocarcinoma. So this is based on the morphology of the cells itself. But after 2007, after we apply the molecular test to lung cancer, this one diagnosis and three diagnoses become these many diagnoses. So we start defining the cancer based on what type of mutation we find in this cancer. For example, the adenocarcinoma, now we have EGFR positive adenocarcinoma, KRAS positive adenocarcinoma, ALK positive, HER2 positive, BRAF positive adenocarcinoma. And similarly, in squamous cell carcinoma, the diagnosis is not squamous cell carcinoma anymore. So it's now the diagnosis is FGFR1 amplified squamous cell carcinoma, EGFR mutated squamous cell carcinoma, or DDR2 positive squamous cell carcinoma, etc. So it makes our job as a pathologist or as a doctor actually harder, but it has a tremendous advantage for the patients, which I'm going to talk about later. So what do we do in the molecular testing? We use the DNA sequencing, RNA sequencing, molecular biomarkers, and we use all of these methods to inform the treatment decisions and also the prognosis. In the institution where I work at right now, we mostly do the DNA testing basically from the slides. And this is very advantageous because in order for us to diagnose cancer, after the patient have the cancer resection of the biopsy, we will put the cancer cells in the slide, in the paraffin slide, and these slides can last for decades, for more than 10 years. So we can always go back to these slides and we're going to identify which area of this tissue, this paraffinized tissue, has tumor cells in it, and then we're going to extract, paraffinize them, homogenize, extract the DNA or RNA, and we do the sequencing. So that will bring me to the next topic of discussion for today, which is how are we testing how do we do the molecular testing? So I'm not going to talk too much about the PCR because I know this is a very popular assay to do, and a lot of you is very familiar with this, but essentially in PCR, we extract the DNA or RNA. This is an example from the nasopharyngeal cancer, for example. And after we extract the DNA or RNA, we run the PCR, regular PCR or real-time PCR. And then after the PCR, we can either stop at the PCR using the primer targeted into like whatever gene that we are targeting, or we continue the amplified fragments of this PCR result into a sequencing. So in sequencing, we determine the precise order of the nucleotide of the DNA or the RNA molecule. The DNA sequencing is more common than RNA sequencing. And the RNA, but we still can do the sequencing from the RNA through either the cDNA generation or direct single molecular RNA sequencing. And the most common, the method for sequencing that is commonly used is Sanger sequencing. And then after Sanger sequencing, there's a next generation sequencing or ultra deep sequencing where we can sequence like a lot of fragments and a lot of specimens at the same time. So this saves a lot of time and a lot of effort. And now we even have what we call third generation sequencing, which is basically a combination between the Sanger and the next generation sequencing. So this is the sample of the RNA sequencing when we have a primer attached to the template. And this template is going to be run into this capillary. So this is basically very similar to the electrophoresis that we do in PCR. But instead of running it into a gel, we run it into a gel capillary, and then all of these bases are going to be detected by the laser and then translated into the bases, the sequence of the bases. Sanger sequencing is very popular, and this is the method, one of the sequencing method that is widely used and even is still used quite a bit, even now with the next generation sequencing. But the advantage of next generation, I should talk about the limitation of the Sanger sequencing. The limit of detection of Sanger sequencing is more than 20%. So if we have a fragment of a sequence or a fragment of a gene that is not as it's not as highly concentrated, we will not be able to detect it with Sanger sequencing. So that's the first aim of why the next generation sequencing is developed, is because it's more sensitive. It can detect the variants up to 1% of reads. The next generation sequencing is also can be highly multiplex. We can run between 500,000 to 1 million molecule sequence in parallel per run, while Sanger sequencing, we do it one by one. And then with next generation sequencing, we can multiply it. So by multiplying, it means that from one patient, we extract the DNA from one patient, we can attach a barcode, or we call it MID, or multiple identifiers to the patient's specimen, or like the patient's DNA specimen, and then we can run it at the same time. So basically, we can run, say, 100 patients at the same time, and then after the sequence is done, we can separate the patient sequences based on the barcode. So each barcode will determine like who is this sequence belong to. So this saves a lot of time, because in Sanger sequencing, 1 tube can only consist one specimen from one patient. The read length of the next generation sequencing is a tad shorter than the Sanger sequencing, but the third generation sequencing is said to be able to sequence DNA or RNA up to 1 kilobase pair. So these are the sample of the next generation sequencing that we have. The 454 pyro sequencing is, unfortunately, this doesn't exist anymore. The one that is commonly used is the Illumina sequencing. This is based on the dye terminators. So the concept is very similar to Sanger sequencing. Ion Torrent is also one of the most common platform of next generation sequencing, where it uses the semiconductor based detection of the system. And then the single molecule real-time, or SMRT sequencing, this is what some people call the third generation sequencing. So basically, the SMRT can detect a very robust amplification of the DNA molecules, but at the same time can do a sequencing for the sequence that has a very, very long base pair. So this is one of the example of how we attach a barcode here. So for example, this is the HIV genome from one patient, and then we attach the barcode here. So we can do the sequencing from multiple patients at the same time. Okay, so next, we're going to the fun part now. We're going to talk about the molecular application in cancer diagnosis. So I want to start this with a clinical case that we had a few years ago. So this is a 52-year-old female who came to our hospital. She's a non-smoker. She complained that she has a dry cough, but the reason why she came to the hospital is because she has headache. So because she has headache, the doctor at the emergency department did a CT scan, or no, this is actually an MRI. And then when they look at the MRI, sure enough, they saw this mass here and also another mass. So this kind of like well-circumscribed mass is very suspicious as a non-primary brain cancer. What it means is because there are multiple masses and the mass is pretty well circumscribed, it's not ill-defined. So at that time, the clinical team at the neurology team was actually suspicious that this tumor doesn't come from the brain. It comes from someplace else. So because the patient also complaining of dry cough, the next thing that the clinical team did at that time was to perform the chest X-ray and followed by a chest CT scan. So from the chest X-ray here, the clinical team saw like the mass in the lung, and then they did a CT scan, and sure enough, from the CT scan, they saw that there's a mass in the lung here. So at this point, even though they were thinking more like this is probably come from the lung that is metastasizing to the brain, but we also don't know. It's still possible that this is a brain tumor metastasizing to the lung. But since it's easier to biopsy the lung than the brain, because to biopsy the brain, the patient have to go into the OR and have an open brain surgery for the biopsies. So we chose to do the biopsy through the lung. So if you can see here, there's a needle. This is a CT scan guided biopsy where we put the needle guided by the CT scan, and this needle goes straight to the tumor. And we did the biopsy of this tumor. And the result is this is a lung adenocarcinoma. So based on the histomorphology, we diagnosed the patient with lung adenocarcinoma. However, since there's already a mass in the brain, we diagnosed the patient with the stage 4 lung adenocarcinoma, or the lung cancer that's already have a far metastasis or far spread to the brain. And the thing about lung cancer is it's bad news. Lung cancer is bad news. I don't know if you're as old as me, but if you are, you probably remember an Indonesian singer. I think this is back in the 90s, Krisya. He's a very famous singer, has a lot of famous music, and he had lung cancer at the time. He was a smoker, so I think his cancer was it's not adenocarcinoma, it's a squamous cell carcinoma, but nevertheless, he had lung cancer. And he was diagnosed with lung cancer, and it was already metastasizing to other organs. And despite all of the treatment, despite all of the funding, the money, and he even seek treatment outside of Indonesia, he succumbed to the tumor and he passed away. That's how bad lung cancer is. So if we look at these numbers, if you are diagnosed with lung cancer in stage 1, which is isolated only to the cancer, only to the lung, the survival rate, the median survival is between 17 to 32 months. But in patient with stage 4 cancer, the survival, median survival is 36 weeks. So you see like how much worse a stage 4 lung cancer is compared to stage 1 lung cancer. Not to mention that 32 months itself, it's not a good survival rate. It's a bad survival rate, but it's even worse for patients with stage 4 lung cancer. But yeah, lung cancer is bad news. But I have a good news. It's getting better. So if we look at this data from the NIH in lung cancer, we see a trend of the decreasing of the mortality rate the number of the patient who died because of lung cancer. And in 2019, this actually have a significant decrease in the death rate of the patient who have lung cancer compared to the year of 2000. So there are several reasons why lung cancer, why lung cancer survival rate is getting better. One of them is the campaign of anti-smoking. People stop smoking, and that actually, when people stop smoking, it makes the chance of the patients getting cancer lower. The early diagnosis. Now, if the patient who smokes, we put the patient through a screening, to a CT scan screening, so we caught the patient early enough in stage 1. But what I'm going to discuss today, of course, is related to the molecular testing. So this is lung cancer. The discovery of lung cancer is one of the big discovery in cancer. So this is a picture of the EGFR mutation, which I'm not going to explain because, as you can see, this is a very complicated picture. But the point is, years of research in genetic mutations in lung cancer has brought us to the discovery that there is a molecular heterogeneity in lung cancer. So there are many alterations in our mutations involving many pathways in lung cancers. And one of the most important discovery in the molecular profile of the lung cancer is the discovery of the inhibition of tyrosine kinase domain of epidermal growth factor receptor, or EGFR. We call it EGFR. So the discovery of EGFR is very important because it doesn't just tell us that there's an EGFR positive lung cancer and there's a EGFR negative lung cancer, but it allows us to find a drug that actually block the EGFR or anti-EGFR. So the FDA, so there is a drug discovered, and the FDA approved this drug in 2003. The drug called gefitinib, and this drug can be used for the patient with lung cancers who fail to the primary or the secondary treatment with the traditional treatment such as chemotherapy. So these are some of the studies that showing how the first study in New England Journal of Medicine is comparing the gefitinib and the carboplatin paclitaxel. So the carbopaclitaxel in pulmonary adenocarcinoma, or the lung cancer, is the traditional chemotherapy. So this is the standard chemotherapy that everyone will get if they have lung cancer. And this study compare the efficacy of the traditional treatment of cancer compare with the anti-EGFR or with gefitinib. The second study here shows that the EGFR mutation in lung cancer actually correlates with the clinical response to the gefitinib therapy. So in other words, if the patient have an EGFR mutation and treated with gefitinib, it's actually make the outcome of the patient better. So if you look at this graph, we can see here that this is the patient, the probability of the survival of the overall. We can see here that the patient who was treated with anti-EGFR actually have a better survival rate. And these are the patient who has EGFR mutation, whose cancer have EGFR mutation, actually have a better survival rate if they are treated with gefitinib. And then, interestingly, if the patient is EGFR negative, the gefitinib is actually have a worse survival rate. And if we don't know the status of the EGFR, then the treatment with the anti-EGFR or with gefitinib is actually have a better survival rate compared to the traditional cancer treatment. So what these studies is telling us is, first, we can start separating lung cancer patient based on their EGFR mutation, EGFR positive, EGFR negative. And if the patient is EGFR positive, we can actually treat the patient. We actually have an alternative treatment for this cancer other than the traditional chemotherapy. So let's go back to our case. So in early 2001, the patient was treated with the traditional treatment with carboplatin paclitaxel, which the patient responded for a while, for only 6 weeks. But then after 6 weeks, she had a worsening disease and keep progressing until 8 months later. So the success of the traditional treatment only lasted for 8 months. And then after that, the clinical team decided to treat the patient with another drug, cetuximab, which is a monoclonal antibody. The patient only responded in 4 months, and then the patient disease progressed again in 2002. And then in mid-2002, the decision was made to treat the patient with anti-EGFR, and the patient sustained response for 30 months, and the patient actually survived the cancer. So I hope at this point I have convinced you that the molecular testing at least have a place in the cancer diagnosis and cancer treatment, and it can help us to help the patient to achieve a better survival rate. And the next topic that I want to talk is about the molecular application in cancer prognosis, or like predicting if one patient will be progressing faster than other patient. But since there's no role in this test for diagnosis, and in a sense, there's no role for treatment, why do we care? Why are we spending so much money and so much effort and expertise to test the molecular just to know whether the patient have a good prognosis or not? So I'm going to talk a little bit about, we're going to switch gear a little bit to lymphoma. So in lymphoma, one of the most common lymphoma is we call it DLBCL of diffuse large B-cell lymphoma. Again, the molecular testing has changed the way we categorize the DLBCL of the lymphoma from decades ago to now. Like, again, when I was in medical school, I think the way we diagnose lymphoma is just large B-cell lymphoma or small B-cell lymphoma, and period. And the patient have the same drug for everything. But then later on, we discover there is a gene mutation in some patients with diffuse large B-cell lymphoma called a MYC-Ig rearrangement, or MYC immunoglobulin rearrangement. So the MYC-Ig rearrangement is a negative predictor for survival in DLBCL. So this study shows that the patient who have a MYC mutation will progress faster and have a worse survival rate than the patient who doesn't have any MYC mutation. But again, the question is like, okay, so we test the patient for MYC. Yeah, some patients have MYC mutation, like, we're very sorry, then you're going to be progressing much faster than the average patient with DLBCL, because as some of you might know, that DLBCL, one of the cancer that can be treated successfully with the traditional chemotherapy. But in patient with MYC mutation, while the traditional therapy can work, usually it doesn't last as long. The question is like, well, even though the patient have a MYC mutation, right? So what's the point of checking the MYC mutation? Because we will treat the patient with CHOP anyways, with the same chemotherapy anyways. But the answer is we need to think about the future. Like, while in some countries, I know that not all countries have an established stem cell transplant, but like it or not, we're going to move towards that direction. So knowing that some DLBCL patients have a MYC mutation, and knowing that this patient will progress faster to a worsening disease, what we can do, or what we do in our institution, is we actually put the patient on the stem cell transplant list the minute we diagnose it. Like as early as possible as we diagnose the patient. And the reason is because we know that this patient is going to progress like quickly. So we're not going to wait until the chemo is successful and wait for 6 or 8 months or 1 year after that. And then if the treatment fail, then we're going to put the patient into a stem cell transplant list. But for the patient with MYC mutation, we're going to put the patient into the transplant list as soon as possible. We're going to try to find the donor as soon as possible. We're going to be more aggressive with the treatment, wipe the cancer out, and put the patient in the stem cell transplant sooner. And this actually make a survival rate for the patient with MYC mutation better. So even though it sounds like this molecular test is not as it doesn't have as much impact as, let's say, test for EGFR, where we test for the diagnosis and for the treatment, but it still have a place in how different we can manage the patient with cancer. The downside, cost. It's expensive. We have to admit, sequencing is very expensive. And it's not just expensive, it's very difficult too. So we need a special technician who can actually run the PCR, who is very well trained, even though I know that we have a lot of people who can actually do sequencing in Indonesia, but it's a difficult test to run. It's not just a kit that comes from a company and, you know, with a few pipetting. It has a lot of finesse to it. And the technology itself is expensive, so it's not a test that we can have everywhere. So even in a state as big as New York, we don't have the next generation sequencing or the option to do sequencing everywhere in the state. And most of the patient in, let's say, a smaller city, they usually ship the specimen to us in New York City, and we run it in the bigger city. But the good news is, since the preservation of the DNA and RNA, the technology to preserve the DNA and RNA is so good right now, we can mail it. It's so much easier to send a specimen to a centralized place to run the sequencing. So that's the accessibility. And then the sampling. Sometimes we have a giant tumor with a lot of sample to work with, but sometimes some cancer has a lot of necrosis. The cells are dead. We can't extract any DNA, we can't extract any RNA. So it's harder, or the cancer is very, very small. And but we know, even though the cancer is small, it can be very deadly. So it can be very difficult to test. So we need a better test where we can utilize a very small amount of specimen for, but still have a robust result with sequencing. So to summarize, the molecular testing have changed the way we categorize and diagnose cancer. This is a very complicated picture. I'm not going to talk about this in detail, but what I want to show here is, this is the WHO category for brain cancer. This is the 4th category. I think this is 2009, and this is the 5th category, which is 2022 or 2023. And the diagnosis is very different. Another anecdote. So about a week ago, I was working at the frozen section. So a frozen section is when we diagnose the cancer quickly while the patient is in the OR. We do this a lot, including in Indonesia. So what happened is the patient, the surgeon opened the brain and then take a small specimen of sample, a small sample, and then send it to pathology to us. And then we freeze the tissue, make a slide, and look under the microscope and decide what cancer this is. I haven't been rotating in neuropathology in more than a year, so I wasn't really familiar with the diagnosis. So when I look at the slides, I told my attending, oh, this is a glioblastoma, one type of a brain cancer. And he was like, oh, no, you cannot say that. And I was like, why? Why can't I say that? It's like, no, we can only say this is a high-grade glioma, maybe favor glioblastoma. And I was like, why? And he was like, because in order for us to diagnose the brain cancer with glioblastoma, we have to have a proof that this is an IDH mutated or IDH wild type. So we have to have a molecular proof that this is a glioblastoma, because there are cancers, there are glioblastoma that morphologically it's really look like glioblastoma, but the molecular test doesn't support that then the patient is not going to be treated with as a glioblastoma. It's going to be treated the way what the molecular say what the type of the cancer is, to the point where we joke that in the future we won't need any neuropathologists anymore. In the risk of some neuropathologists probably will be upset with me, but we often joke in the future that we won't need a neuropathologist, because we're just going to do a molecular testing on all of this tumor and categorize this cancer based on the molecular testing. So to close this discussion, I just want to emphasize that the molecular testing has become a major part in many tumor type assessment, and the integration of the molecular is paramount for a better cancer management. It causes a lot of headache to the pathologists, to the doctors. We often joke, being a pathologist 20 years ago is way easier because the diagnosis is so much simpler. But being a pathologist right now is so much harder because we have to learn about molecular, we have to learn about the different treatment, the different categories for cancer. But in the end of the day, this is why we do research, right? Like, this is why we become, in my case, I became a physician, and this is why we do research. Why do we do it? Because we want to make a better future for our patients. We want to make human life better, and maybe someday we can make cancer a history. We can treat cancers, and that's the goal. So, like it or not, I know this is complicated, but molecular, it's coming. So thank you so much for listening to my talk, and I am happy to take any questions.
Okay. Wow. Thank you, Dr. Ivo. That was a very insightful presentation. At first, I don't really understand what molecular testing, because my background is not really relevant with that. But as I follow your presentation, I try to understand. And I would like to highlight your last sentence about better future for our patients. So it's like, despite its complexity and high cost, the molecular testing offers a benefit for the diagnosis and also the treatment or therapy decisions for our patient. And
Correct.
that is a very big dream, if cancer is really a history in the future.
Yeah. But if we don't dream, we're not going to ever achieve that. So we're not going to try, right? So every result, every effort starts with a dream.
Yes, of course. We have to preserve our dreams and pursue our dream. Okay, now it's time to question and answer. Okay. There are, but you can drop the questions in the chat box. I already saw that there are some questions in the chat box, but before moving to the question in the chat box, you can use your raise hand features to ask the question live. I would like to see if there is any questions. Any of you would like to ask directly? You can use Bahasa Indonesia as well. Anyone? You check. Okay. I couldn't find any. Is there anyone raising his or her hands? Committee, please. Mbak Miska or Mbak Sundari, do you see anyone raise want to raise the question live? Okay. I don't think so. Okay. but there are quite several questions in the chat box. Dr. Sidik, can you please show in the screen? Okay. Okay, so let's start with the first. Okay, the first question I think from there's a lot of questions coming from Novianto Giar Pangidung. I want to ask Dr. Ivo, based on your experience, how effective and accurate? Okay. Okay, that's quite a lot. Okay, this is from the first one is from Dr. Anton. Are targets such as HER2, EGFR, EFGR, mutation, BRAF mutation, LK, and ROS specific to only one disease, or can they be expressed in multiple diseases? How can we address the challenge of non-specific markers and the need for comprehensive screening to make precision medicines? Maybe we can start with the first question, Dr. Ivo.
Thank you. Thank you, Dr. Anton, for the question. It's an excellent question. And the first answer is yes. So targets such as HER2, EGFR, BRAF is not exclusively belong to one certain cancer. Yes, for EGFR, the most common EGFR mutation, we often see it in lung cancer. But HER2, we see it in lung cancer, but we also see it in colon cancer. And BRAF, we see it a lot in soft tissue cancer and also in thyroid cancer, for example. ALK is practically everywhere. We see it in lymphoma, we see it also in lung cancer. So it can be expressed in multiple diseases. But the beauty of molecular is EGFR mutation is EGFR mutation. If you have EGFR, so for example, or I should say HER2, because we also have drugs for HER2 mutation. We have trastuzumab for HER2 mutation. HER2 mutation is HER2 mutation. Either we discover it in breast cancer or we discover it in colon cancer. If we are convinced that this patient have a HER2 mutation with the high tumor burden, and we decide that we're going to treat the patient with trastuzumab, then the drug is going to be the same, either for colon cancer or for the breast cancer. And the second excellent point that Dr. Anton said here is that how are we going to do a comprehensive molecular testing in these diseases, in these cancer patients? So I know I got excited about molecular because I personally love molecular, but we also have to remember that molecular is only one aspect of the diagnosis. I was joking about not needing a neuropathologist. Like we still need a neuropathologist. Like I am a pathologist, so I hope that my job is not going anywhere. But when we diagnose a cancer, we have, I like to see a patient as a whole, as a patient itself. So we don't just see like, the patient have an EGFR mutation. It's a lung cancer patient with the EGFR mutation, for example. Are we going to treat the patient with EGFR or not? I will not automatically treat the patient with anti-EGFR because I want to see like what stage the patient is. For example, if the patient is stage 1, so the cancer is only isolated to the lung, it's not a stage 4, and there is a chance that we can be successfully treated the patient with surgery because the cancer is small enough, then we're going to do that. Why? Because this drug also have side effects, have a lot of side effects. And this is the drugs that is relatively new. So we know the immediate side effect, but we don't understand fully the long-term side effects of these drugs. So I hope that answer the question that we have to be comprehensive. We have to look at the organ itself, where's the cancer come from? And second, we have to look at the morphology of the histopathology and the morphology of the cells itself, what type of cancer. And then that's why we still call molecular as an ancillary test, as an additional test to help guide us in treat the patient more specifically.
Okay. Yeah, we need a comprehensive test. Dr. Anton, do you want to? Oh, okay, it's already there. But I would like to ask whether Dr. Anton want to have a follow-up questions from the first questions. Dr. Anton, are you there? Okay, if no, let's move to the next questions from Nurfianto, the one in the chat box, I think. I've read this. I've read this before, and based on your experience, how effective and accurate is cancer detection via molecular testing compared to other detection approaches such as radiopharmaceutical or biosensor approaches? And there's the second question. What about molecular and gene analysis tests for cancer therapy through genetic engineering, both in clinical and clinical trials, if they have been widely developed after passing clinical trial? Okay.
Thank you. Again, great question. So I have to give a disclaimer first because I'm not really familiar with the biosensor. So I never studied it. I only read about it, know about it, but not super familiar about it. But either way, either it's molecular or biosensor or other modality, is our job as a scientist is to prove that this test is actually working. In the field of molecular diagnosis for cancer, it has been around for a very long time. So this we follow the patient in a very long period of time, knowing that this mutation actually is correlated with the cancer that we have. And I can imagine that biosensor is probably going to have a similar validation that this test is actually working for this cancer. But I have to apologize, I am not familiar with it. But in the field of pathology, I believe that molecular is more commonly used. It's not necessarily mean that the molecular is more effective than other methods. It's just because it has been around for a longer period of time, and it has been proven for its efficacy in the diagnosis and predicting the prognosis, then we use it more often. As for the genetic engineering, so there is no approved test for the genetic engineering. It's still in the clinical trial. However, we do a lot of CAR T cells in our institute. We have an institute for precision medicine in our university and in our hospital. We do use CAR T cell, which can be categorized as the genetic engineering for patients who failed treatment with the first and the second generation, with the first and second treatment. So if the patient go to the Institute of Precision Medicine, then we decide whether we're going to continue with the drug, with the more targeted drug, or if it's time for us to put the patient into a CAR T treatment. But this is not a widely used treatment. It requires a special approval from FDA. So it's not like a generalized, there's no umbrella approval from FDA for this treatment. So we actually have to apply for the approval for each patient. So we have to have an IRB, we have to have an approval from FDA for each patient. Again, because this is still experimental. But these patients are usually very sick. So this is our last effort. Sometimes it sounds like a Hail Mary, but if we don't do this, the patient is going to die anyway. So we might as well try to save the patient's life, or at least buy sometimes, you know.
Yeah, that's understandable. Yeah, we buy sometime. Yeah. Okay. Yeah. I think since we have quite a lot of questions, so I would like to go on. I'm sorry, Dr. Siti, I think we missed the second question. Yeah, okay. Yeah, from Ibu Sri Hartati dari Pusat Riset Tanaman Perkebunan. Also, she is asking about the difference of biopsy technology with the molecular analysis. I think it's quite, the question is quite similar, but maybe you can, okay, Dr. Ivo, maybe you can explain further about this. Is the
Sure.
different of technology? Yeah.
Yeah, I apologize if I didn't. I was trying to make my talk into a 40 minutes talk, but I should have explained about the difference, sorry, of the biopsy and molecular. So when someone is diagnosed with cancer, either from radiology or for clinical, sometimes we can see it clinically, right? Like skin cancer, for example, you have an ulcer. It's a very unique appearance of cancer. The first thing we're going to do is we're going to do biopsy. So biopsy, before we even talk about molecular or like think about molecular, the biopsy is always the first step that we do. So in biopsy, we take a tiny specimen, a tiny tissue of the cancer itself, and then we embedded them in paraffin, slice them, stain them, and then we look under the microscope based on the cell appearance, the morphology, and the histopathology. And most of the time, I would say 90% of the time, we can diagnose this based on morphology. And then in addition to that, we also do immunohistochemistry where we can stain the cells. Like, for example, if some adenocarcinoma, some glands, it's going to look very similar between, say, a gland that come from one organ or the other. So we can add an additional staining to determine like where are these glands or the cells come from. And then after we have the diagnosis based on the biopsy, and then we move to the molecular. So again, molecular is considered as an ancillary test. It's not a standard test that is done in every cancer, because there are some cancer where we don't even need a molecular, because it can be, for example, the most common cancer in human being is basal cell carcinoma. It's a skin basal cell carcinoma. The treatment for basal cell carcinoma is surgery. We're not going to do any molecular tests for that because we know it's a basal cell carcinoma and we know the best treatment is surgery. So we stop there. So that makes a molecular testing is totally unnecessary in this kind of like cancer, for example. So I hope that answer your question, the difference between the biopsy and the molecular analysis. So the molecular analysis basically is just an additional test for the biopsy.
Yes, the ancillary. Okay, I think Dr. Ivo, you can see there's a lot of questions in the chat box, and unfortunately, we will have only around 8 to 10 minutes. Yeah, but let's have another 2 or 3 more questions. I think we still have time. This is the third question, so maybe to cut the time, you can just read and answer.
Sure. So positive mutation in NGS. Yeah, we do have the drug for that. We have for ALK, I think. So what we do for the cancer is we don't we have a test for EGFR. We call it rapid EGFR because it's a very common mutation. And the turnaround of the NGS is actually 2 weeks, which is sometimes it's too long for the surgeon. So we develop like a more rapid test like for EGFR. But again, this rapid test can only detect EGFR. For ALK-EML4, I don't think we have a rapid test for that, at least in my institution. So it is actually part of a panel. So we have a TSO500, a panel called TSO500 and Oncomine. So this panel is basically an NGS that detected over 50 different genes for different cancers, 50 different mutations 50 different gene mutation. And ALK is included in that panel. And it's very, it's very sensitive actually for ALK because in hematopathology, in blood cancer, there's actually a category for ALK positive or ALK negative leukemia, and we use that a lot. And for ALK, we can actually use staining, even though NGS is more sensitive, but we actually have immunohistochemistry that the staining is basically can stain if there's an ALK mutation in the cells. So I hope this answer your question. To save time, I'm just going to go to the next question.
Yes.
Student conducting research on long non-coding RNA, and despite all the techniques I have learned so far, sometimes I wonder if the implementation in Indonesia. Yes.
Yeah, of course.
I can totally relate to this. We have to believe that someday it's going to happen, and I really believe that this is going to happen. We have a NGS at the University of Indonesia, and I know IMERI has a lot of NGS, and even companies like Biopharma, they also have next generation sequencing. The equipment, yes, it is very expensive. So I have to admit it's hard sometimes to do it in Indonesia because we don't have enough funding for this. But do not be discouraged because I did my PhD almost 10 years ago. And if I stop at that time because I couldn't do the HIV because my field is the viral genetic and also the cancer-associated cancer-associated viral diseases. If I stop at that time, I will not be able to be at my place right now. So my suggestion is to collaborate because there are a lot of Indonesians out there. Name any country with a good research, there will be an Indonesia. Reach out to these researchers and talk to them. And maybe this is an unpopular opinion, but sometimes we cannot do it in Indonesia, but it's okay. As long as we still contribute to the development of the technology in Indonesia. One of the hardest decisions that I had to make at that time was to stay in Japan and move to the US because I wanted to go back to Indonesia, but I couldn't do my job. But I ended up doing a lot of collaboration with the University of Indonesia, with Biopharma. And once we open our mind and we start collaborating with anywhere who wants to collaborate with us, the sky becomes the limit, basically. You will find funding, but I'm not going to lie, it's going to take a lot of hard work and a lot of effort. But I believe Indonesian students are one of the most brilliant students out there. And I'm speaking based on experience. I have multiple students, American, Japanese, Indonesians. Indonesians are one of the most brilliant students I have.
Wow.
So
Great.
Keep doing it.
Semangat Mbak Dian. Okay, this is my colleague Mbak Dian. Okay, and move. I think, Dr. Ivo, do you mind if we have we extend like around 10 minutes or 5 or to 10 minutes?
Sure.
Okay, so we can go on.
So is all the cancer have a molecular diagnosis, or is there any research that is still doing? No, well, the answer is no. Not all of the cancer have the molecular diagnosis yet, but it's advancing really fast. And yes, we are doing a lot of research associated with molecular disease, and this is very important. Another example is liposarcoma. So this is one of the cancer that can be very hard to diagnose. So this is a very aggressive tumor, some generated from the fat, but sometimes it's very difficult to determine whether this is a cancer or just a tumor, like a benign tumor. The discovery of MDM2 gene changed the diagnosis of liposarcoma and make it so much easier for us. And that took years and years of research. And one of my professor actually at Cornell is one of the people who spent 30 years developing a marker for tumor, like or a mutation for tumor. But yeah, unfortunately, not all cancer have the molecular mutation that is identifiable yet. Yes, there's a lot of research, and this is an exciting research, and the field is evolving very rapidly. So I hope that with this talk, I can convince everyone to start reading and make yourself familiar with molecular testing because it's coming, and it's going to make the prognosis for the patient better. I hope that answered the question. So the next is molecular tests are expensive, take quite a long time. Hang on, I need to close this. What is the most what do you think is the most efficient implementation that can be adopted in Indonesia? Short term, probably centralize it. It's a really difficult test to run. I think centralizing it instead of like developing multiple tests at multiple places, it's better to have a few centers in big cities where all of this test is centralized. It is expensive, but it's actually way cheaper than 10 years ago. NGS 10 years ago is very expensive. Now it's probably only 1/10 of the fraction of what it used to be. So it's much, much cheaper. So it's doable. This technology is evolving to not only making a new marker for cancer, but also to make this test cheaper. But if we don't centralize, it's going to be difficult to find to maintain the quality of the test itself. So in my opinion, the most efficient implementation is to centralize it and try to collaborate, because all of this test is already developed in many, many institutes, and including my institutes. We are happy to share the technology. If you will be able to do it, if you have the machine and the technique, and we have the panel, we are more than happy to share it with anyone who can use it, because in the end of the day, we just want more people to use this tool to diagnose cancer. I think that is the most efficient implementation until more places can actually do the molecular testing. I hope that answered the question.
Yeah. Actually, we still have some more questions, but Dr. Ivo, do you mind if answer the questions like in a written format, and we will distribute better?
So I am happy to share my email.
Okay.
I cannot promise that I will be able to answer it soon, but I will try my best to answer every questions. I will give my email to Pak Harimat, so or I can actually type it here. And unfortunately, I can't stay longer. I would love to listen to Eva's talk, but unfortunately, I have to be at the hospital at 6 a.m. tomorrow. But I will leave my email address here. So if you email me the question, I will try my best. Hopefully this weekend I will have time to answer your questions one by one. And I really appreciate this invitation. And I also really appreciate all of these questions. I am really touched that people are actually interested in what I'm in my talk, because this is a field that I'm very passionate about. Thank you so much. I will leave my email address here. And if I can't, then I will give my email address to Pak Harimat.
Okay. Thank you, Dr. Ivo. That was a really engaging discussion and a very lively session. So, and
You're very
as a
welcome.
talk, yeah, I really enjoy it. I thought I would not really understand, but oh, yeah, this is excellent. Okay, as a token of our appreciations, we would like to present you with an e-certificate. So, Dr. Ivo, and Sahbandar MD PhD. This is the certificate for you. And we are thank you once again for your valuable contribution in this international seminar.
You're welcome,
Okay.
and it's my pleasure.
Yes. Okay. Thank you again, and good luck for your jobs and for your research in the efforts. Thank
Thank you.
you, and see you later. Okay. Okay. Okay, everyone. So that was really interesting, but we still have two more speakers, and our next speaker is Eva Suwartana, MD, PhD, and yeah, she is can you please share the no. Okay. Yeah, this Dr. Eva is currently a planning, programming, and research officer at the Health Technology Assessment Unit at the McGill University Health Center, Canada, and also a young professor in the same university in the Department of Obstetric and Gynecology, and also research associate. Dr. Eva got her medical doctor in the University of Indonesia, similar with Dr. Ivo, and MSc in clinical epidemiology from the IHAS, the Netherlands Institute for Health Sciences, and her PhD was gained from the Utrecht University from the Netherlands, also from the Netherlands. And she has joined a postdoc at this is the Center for Disease Control and Prevention USA, the CDC. And there are some publications, of course, quite a lot, and we can check it later. And yes, thank you. I think in Canada, Ibu Eva, are you in Montreal or?
Yes, I'm in Montreal.
Okay, so it is already night there, just like the same in New York, if I'm not mistaken. Yeah.
Yes, yeah, we're in the same time zone. So
This
so
is
it's 10 p.m.
10 p.m. Oh,
Yeah.
10 p.m. So, okay. So this is the first time, and nice to see you, Dr. Eva. I already read through some of your bio and find it very interesting. And we please welcome our next speaker, Ibu Eva Suwartana. She will be speaking on development, evaluation, and dissemination of novel clinical tools for predicting occupational asthma. Dr. Eva, you have 40 minutes to speak, and let's welcome her. Please.
Thank you so much, Bu Yuyun, and thank you for the opportunity for me to present our work here. Thank you for the invitation for Pak Harimat and Prof. Indi and the committee for me to join you today. Okay, let me share my screen. Okay, can you see the PowerPoint?
Yes, we can see it, and we can slideshow.
Okay, thank you.
Okay,
this is already full screen, yeah?
Not yet. Not in our monitor. It's already in yours?
Yes, yeah.
I think that's
okay. It happened to me, I don't know. Still not working? Maybe then Ibu Miska can share. Yeah, I already shared the PDF to her.
Yes. Maybe you can okay. Ibu Miska, please. Yeah. Yes, it is now in the slideshow.
Yes. Okay.
Please.
Thank you
Yeah.
so much. Okay, so thank you again, and sorry for the technical problem. Okay, next slide. Okay, so the outline for my presentation, it will be like, first I will talk a little bit about work-related asthma, continued with the development and validation of clinical prediction model, or CPM, for work-related asthma, and how we can apply the model in practice, and some future perspective. Next slide. So work-related asthma has two entities. Like, first is occupational asthma, which is asthma induced by agent in the workplace. So these workers, they didn't have asthma before they started working. And once after they're exposed to the agent in the workplace, they start having asthma symptoms. The second type is called work-exacerbated asthma, or WAA. So these workers, they already have asthma. They have pre-existing asthma or concurrent asthma, but it was worsened by workplace exposure. So there's the difference between the two entities. Next slide. So there are about, I think there are more than 300 agents already like known to cause like work-related asthma. We differentiate them into two categories, so based on their molecular weight. So we call it the high molecular weight, or like HMW. They're mostly protein. The most common type of agent are flower and laboratory animal allergens. And the second type is the low molecular weight agent, or LMW. They're mostly chemicals, and the most common exposure are cleaning products, isocyanates that are like we can be found in paints and wood dust. Next. So these are the profession with exposure to high molecular weight agents. So as you can see, laboratory technician, they work with animal allergens, so they are prone to develop work-related asthma. The same thing as people who work in the bakery, in the baking industry, because they're exposed to flour or alpha amylase, like the agent to improve the dough, or people in the healthcare industry who work with latex. I'm not sure. I think like in Canada, at least I know, like it's been maybe more than a decade. They don't use latex anymore, but I'm not sure in Indonesia. But these are like known exposure for high molecular weight agents. Next slide. And for the low molecular weight agent, as I said, that a lot of them are found in like car paints, like isocyanate, yeah, in car paints, and also in wood dust. So these are like type of profession that are prone to be exposed to low molecular weight agents. Next slide. And why work-related asthma is important? Because it can impact the quality of life and also impact the work productivity. Our recent study like showed that compared to like in general asthmatic subject, they have like lower general health than like normal people. But when you compare like work-related asthma versus non-work-related asthma, then work-related asthma subject, they have like much lower quality of life and overall work productivity compared to like asthmatic subject but not work-related. So the implication is, the implication that we need to have holistic approach for these workers. And to start with is like the difficulty that can be that are faced by most of the practitioners, especially in developing countries, is like to have like a standard diagnostic model is very difficult. First, we start with diagnosis, like anamnesis, like we ask question about their exposure, about their asthma symptoms, and once you like confirm that like from symptoms and like history of exposure, then you will confirm their asthma, like asthma state, by having a test. It's called non-specific bronchial test, using either methacholine or histamine. But this test is hardly available in like developing countries. Even I heard from Professor Yunus in Indonesia, we only have one machine in Jakarta. So that is how rare it is, like the complex diagnostic tool for occupational asthma. But we have other like tools. You can also do serial measurement of PEF. So there's also like secondary tool to diagnose occupational asthma. And also we have, so first like you establish the status of asthma, which is by doing the NSBHR test. The second thing is you must confirm the association between work exposure and the symptoms. And you can do it by having a skin prick test or SPT, or hemoglobin E, like in the blood, to evaluate the sensitization from the agent in the workplace. But these two, like as I said, is very difficult to obtain in most developing countries. Here in Quebec, we have a specific inhalation challenge in the laboratory. And SIC is until now is considered as the gold standard. But even in Canada, you can go to the next slide. The next slide. Okay, so this is the machine that we have in the hospital Sacré-Cœur. But even in Canada, as I mentioned here, there are only 3 sites in Quebec, in the province of Quebec alone, that has this machine. So it's very difficult to have the workers like from all over the province to be diagnosed with this golden standard tool. So it is very costly, it's very rare to have it, and it can still have false negative tests. And the complexity to mimic the exposure in the workplace is also very challenging. So that's why, next slide. So, okay, so that's why it comes to like why we try to use clinical prediction model to try to diagnose occupational asthma using much simpler tools, like we will use questionnaire or mostly available tests like PEF or serial PEF as a diagnostic tool. So clinical, for you who are not familiar with clinical prediction model, is basically a mathematical model to quantify individual probability. So we have diagnostic model, which is to identify a health outcome, like the present, like if a person currently have a present like health outcome. Or a prognostic model is a model to predict like the future, if a person will develop a health outcome in the future. Both models have advantages. It can allow identification of individuals at risk, and it can also allow risk stratification for decision making. So it is very helpful to making diagnosis and treatment policy. Okay, next. The algorithm that we propose to use this kind of modeling, for example, work-related asthma, for the surveillance of work-related asthma, we have like worker in the daily workplace that are exposed to aero allergens, and all of them we can apply the diagnostic model to this worker, and based on the model that we use, we can have score, and then we can categorize the score into low and high or intermediate score, and each of the group will have different treatment. or different consequences. For example, people in the low score will not be investigated any further. People in the intermediate score, for example, they will be referred to occupational physician, and people with a high score will be referred to, for example, occupational respiratory clinic to really confirm the diagnosis and start treatment. So this is the role how a diagnostic model or clinical prediction model can help clinician in the practice, especially when we don't have complex diagnostic tool at hand. Next slide. So our study, like we first developed a model for high molecular weight agent. So the objective is to develop model to predict positive, like SIC, like specific inhalation challenge for occupational asthma. And for this, we only use 160 workers exposed to high molecular weight agent who were referred to our clinic at the Sacré-Cœur Hospital. And we use very basic like logistic regression analysis, so it's not very complex modeling. We just use logistic regression and we evaluate the items from the interview, and then we see the added value of extended model, which is interview plus non-objective SIC test. And we evaluate the model in terms of accuracy, internal validity, and also we evaluate the external validity in European data. Next. So this is an area under the curve. For you who are not also familiar with this kind of curve, basically in the x-axis, it is the true positive, like the 1 minus specificity, and in the y-axis is the sensitivity. So a good model will have a high discrimination, which is the ability to differentiate subject or workers with and without the outcome. And the higher the curve going to the top corner of the graph, it means that the model have high sensitivity and high specificity. So that's the best model. So we look at different models. So we develop first we develop the model that only consists of interview items. And as you can see here, the interview has an AUC of 0.75, which means 75% of the workers, in 75% of the workers, we can differentiate those who have occupational asthma and those who doesn't have occupational asthma. And if we add the extended model, so we have interview plus specific sensitization, which is presented by, it should be the blue curve. Let me see. Okay, so the blue curve is the interview model, and the one here, the red one, is when you have interview plus specific sensitization and SBHR. So these three modalities will have an AUC of 0.89, which means almost 90%. In almost 90%, you can differentiate people with and without occupational asthma. So this is a very high value. So we thought, okay, we have a good discriminative ability, so we would like to test it in other population. So next slide. So we try to look at the validity of the model in European countries. It's because they have the data, so they also have some centers that has SIC as their diagnostic, like the gold diagnostic test. So we work with the researcher from Belgium, Finland, Poland, and Spain, and we test the model in almost like 500 workers from these 4 countries. Next slide. Okay, next. Okay. Yes, so these are the characteristics of the workers between, so we have the Canadian and the European. So the first I'd like to show here is the first row, the SIC positive prevalence. in Canada, in Canadian setting, we have 52% of the workers have positive SIC or they have the occupational asthma, while in the all European they have like higher prevalence, like they have 70%. And based on gender, like in Quebec, 75% are male, while in European, 50% are male. But it has to do with the exposure. If you go down to the exposure to flour here, the exposure to flour, they have 73% were exposed to flour in Canada and only 43% exposed to flour in European countries. However, given these like discrepancies, like the differences between the two populations, we'd like to know if we can still use the model in the European workers. So next slide. So when you want to validate the model into a new population, you still look at their discriminative ability, which is the AOC. So I will remind you again that in Canada, in Canadian set, the AOC was 0.89. So when we do the validation, when we did the validation in the European data, when we did a no update method, which means like we just like run the model as it is, we didn't do any adjustment or whatsoever. The AOC is still very high, it's 0.83, which is good discrimination. And when you do more like more complex method to improve the AOC, it didn't improve that much. So we tried like different methods, but still the AOC remained more or less the same, around 0.8. But it's still a good AOC, a good discrimination. And the second one here is the calibration. The calibration, it means like how good is the agreement between what you predict and the actual probability. So if you also haven't seen this graph for this is the first time to see the graph, the x-axis is your predicted probability and your y-axis is your actual probability. So the ideal model will have a straight diagonal line, which means an ideal agreement between the predicted and the actual probability. So when we did a no update method, we didn't do any adjustment. We just run the model as it is in the European. We can see that although in the lower probability, like the model slightly underdiagnosed, like have a lower probability compared to the actual one. But when the probability is above 0.5, it has a very good agreement between the predicted and the actual probability. So we are happy with the result of the validation. Next slide. So given that we have a good discrimination, we have a good external validation, so we decided to transform the clinical model into clinical score, because then the physician can use it like more easier. So for example, we have age above and below 40 years, and if it's like younger than 40 years, it has a clinical score of 8. If they have rhinoconjunctivitis symptoms, it has a clinical score of 33. If they use corticosteroid, inhaled corticosteroid, it has a point of 20. And based on the agent type, the exposure, if they're exposed to flour or like then the clinical score is 61. And if they have like skin prick test, positive skin prick test, yeah, it has very high score, is 100. And if they have also a positive non-specific bronchial hyperresponsiveness test, it has an additional 80 score. So this is like how we transform like model from the logistic regression equation into clinical scores. And next. So we try to, the next step is how to make risk stratification. So we we say if we have like a sum score of a certain, like sum score with a certain predicted probability, which cutoff we have to choose to say this person has a high risk and this person has a low risk. So we need to do this exercise to evaluate like which cutoff we have to choose. And I just like took two examples, like if we choose, for example, a sum score 150, then the sensitivity is like 96%, which is very high, but it comes with referring more workers to do the test. If we pick a higher sum score, for example, 210, it has a lower sensitivity, but a very high specificity, and you refer less workers. So the decision to pick like which cutoff, it depends on your resources. If we have like good resources and like Canada has happened to have like universal healthcare system, so they don't have like the patient will not be charged to have this additional test. So referring like workers are not burdening the worker themselves, but the waiting time is also long. So we have to make like decision like, okay, are we going to refer more workers with the like lower specificity, or do we want to refer like less worker but with a higher specificity? In general, because we are in the setting of surveillance, we want to have like high sensitivity because we don't want to miss a potential worker that will develop occupational asthma. Okay, next slide. So this is like how the clinical application of the model. So once you have set your cutoff, we say, okay, this is a low category, this is a high category, then we can apply the model again as seen before. So those with the low probability be further evaluated with, I'm not sorry. Yeah, so people with the low probability, we will do like, for example, less complex tests, yeah, such as serial respiratory function tests at work and off work. And if it has a high probability, then a prompt action should be taken. Like so, we can start the treatment, and we can, for example, remove the workers from the exposure. And we can, like in Canada, these workers are eligible for compensation, so we can start the compensation claim for these workers. So this is how it can help in clinical practice. Next slide. And once, yeah, because we find the model has a good discrimination, have a good calibration, have a good external validation. We also created an online calculator, so everyone, even in Indonesia, yeah, you can download. It's available in Apple Store, also in Google Play. But if you also want to just like Google online, you can click this link, and you can arrive in the. You can get our online calculator. So basically, we use like there are like 6 items that I already explained. You can easily like fill out the information like the age, the presence of rhinoconjunctivitis symptom, the use of inhaled corticosteroid, if they're exposed or not to flour, if they have like positive sensitization to specific allergen and NSBHR. So you type in all the information, and then next slide. Okay, next slide again. Yeah, so you can have your sum score and because this is online calculator, once you have the sum point, you can have like the consequence, like you can have prompt. For example, if you have 200 300 point, it will say, okay, you have a high probability, so the action is you have to have like a specific enhancement challenge if it's available in your place, and so on and so forth. Or if you have a very low point, like for example, you have 100 point, it will suggest that it has a low probability, so you don't have to do like further testing. So you can like, so for the time being, there is no action to be taken. So something like this, and so it's available online. Everybody can access. And next slide. And for the future perspective, actually it's been going on. Like we got funding from the Canadian Institute for Health Research to develop similar model, but this time for the low molecular weight agents. And we already have collaborator from our other province in British Columbia, and we will use the data from Canada to also, again, we will try to validate the model in European centers. Finland and Poland already agreed to validate the model with us. Next slide. And also, we also look for places where SIC are not available, such as like, especially in like in Indonesia, for example, but also like our collaborators from other provinces in Canada, from Switzerland, from Turkey, from UK. Even they don't have SIC to make final decision with the SIC, so they would like to have to test our model in their setting as well. And once we have all done, then we will create a website, our own website, OCAS Calc, to have our own page, having the calculator and educational page for patient and physicians. Next slide. So these are the team who developed the calculator team. So me, my students, my colleagues from Quebec, from Canada, and European team. And we got the funding also from Quebec government. Okay, next slide. And these are references. So I end my talk here. Thank you so much for your attention, and I'm happy to answer question now.
Okay. So I've read your slides before, and I think about like, oh, so how like in your field, like this occupational is getting a lot of attention, and I was thinking, oh, is it happen in Indonesia? Like we really consider this occupational asthma or something? Maybe we might neglect it to some extent. So yeah, this is the Q&A session. Is there any questions? I hope that there are asthma like physicians who work on asthma related diseases, or that any. Let's
Yeah.
see.
Yeah, we have.
Let's check. Oh yeah, we currently. Is there anyone who wants to raise the question live? Please use the raise hand feature. There are some questions, but if anyone wants to raise the question live, please, because from morning until now, there is no one asked the question live. So I just want to hear if someone wants to ask live, so we can hear you.
Yeah, I mean, just to answer your question, Bu Yuyun, like in Indonesia, actually, like occupational asthma is well known. We have at the FKUI, like Fakultas Kedokteran Universitas Indonesia, we have like a program for occupational occupational medicine. So they are trained to like diagnose workers with occupational asthma as well. But like also, for example, in pulmonology department, all across Indonesia, they are also aware about this like illness. However, as I mentioned, the challenge is to diagnose. Like in the ideal setting, like they have very high like gold standard. This is the SIC, like very hard to do, and the machine that is considered NSBHR, like that I said in the model, is only available one for the whole country in Indonesia. So that you can imagine. So it's very, very, very difficult. So that's why we try to look. We can see like the model, the questionnaire model alone, and then when we add the questionnaire model plus like diagnostic test, the questionnaire model alone is actually like not bad, but not too high precision, but you can still use it. So in places like Indonesia where we don't have like, for example, metacolon challenge test or specific like skin prick test, then we can use this like questionnaire model alone, and it could help diagnosing.
Okay, there's also the other questions, but let's have the first questions from Ibu Sri Daiyani, please.
Good morning, Dr. Eva. I don't know
Morning,
in
Bu
Canada,
Ida.
probably now is
Hi.
evening. Dr. Eva, I hope you can still recognize me because in the past you gave me capacity building with Professor Bastaman, almarhum.
Oh, Masya Allah.
Dr. Eva, I'm interested in about discrimination analysis. I think I'm sorry because I forgot there are so many people beside me. I think invalidation study we just need specificity, sensitivity, ROC, but in fact you use the discrimination analysis. Could you please explain the discrimination analysis in your study?
Yeah, so actually like what I showed you, the graph of the area under the curve is basically you plot the 1 minus specificity against the sensitivity. It's basically it's the same thing, but you combine between the sensitivity and specificity, and you plot how good is the cutoff in your model. So we I don't know, Ibu Mieska, if you can like show the slide, or maybe I can share mine.
Yeah, please share
Okay,
again.
but it's I think page
The graph.
slide number
Is it this?
14. Slide number 14.
14.
14. Yeah, this one. Yeah, thank you.
Okay.
So yeah, Dr. Ida, Dr. Sri. So this is as you can see here. So this is a combination between like specificity and sensitivity as well. But we plotted, for example, if you use this cutoff, then it has a sensitivity of like 80%, but a specificity of 20%, 80% as well. Like if you really like start in the right corner, like if you go down to the orange line is when is only the area under the curve is only 50%. It means that the ability of the model to differentiate between the positive and negative cases, or like those with and without cases, is only 50-50. It's like flipping a coin. It's not good at all. So you don't want to have a model that has an AOC close to 0.5. So you want to have a model that has AOC like far above 5. In this case, the blue line here representing the ability of the model, the questionnaire model alone. It has a area under the curve of 0.75, which means in 75% of the workers, you can differentiate those who have asthma, occupational asthma, and those who doesn't have occupational asthma. If you add specific sensitization and NSBHR, and you move from the blue line to the red line. So you see like the curve is going higher, like it's bigger. So the area under the curve is 0.89, which means almost 90% of the workers, you can differentiate correctly between those with and without occupational asthma. So you always want to have a model with very high like area under the curve. I hope I can answer your question.
Okay, thank you, Dr. Eva. This is the discrimination using the area under curve. I think it is the discrimination analysis that available in like SPSS. So it is different, Dr. Eva. Yeah? This is the area under curve.
Yes, yeah. Good discriminator, and yeah. So from this, yeah, when you actually want to, okay, go to the next two slide, Ibu Miska. Next one. Next. What's it next? Next one. Yeah, this one. Yeah, here. So this is like, so once you have the discrimination, which is measured by the area under the curve, you go like now to see like when you select the cutoff, then you have to look carefully for all the diagnostic measure, like the sensitivity, specificity, positive predictive value, negative predictive value. So for example, here you have a cutoff like 150. So you compare how many subjects with the score above 150 and with the score under 150, like how many, like the percentage of them have like real occupational asthma. So in general, when you use a lower sum score, you will always have a higher sensitivity because you're referring more people. But when you choose a higher cutoff, your sensitivity will go down, but your specificity will go up because like people with the higher score, like those people who usually have more symptoms or more positive diagnostic tests. So that's why this is the balance that you need to choose based on your resources, as I said. If you want to say, okay, I don't want to miss any subject with occupational asthma, then I will choose cutoff that has a high sensitivity. But if you say, okay, this worker will be surveyed anyway in the next year, so I just want to have a sum score that is very specific. So I will choose a higher sum score, which is like, for example, 210 with a high like specificity of 91%. So this is when the discriminative like analysis will be done, is when you really choose your cutoff. And
Thank you very much, Dr. Eva. It's very clear. Thank you, Mbak Yuyun.
Yeah, thank you, Ibu Ida. Yeah, I think that's quite the key, the score, how we choose which score that we want to use. And I think this is the key point that taken into the model of the calculator. Is that right, Dr. Eva?
yes, yeah, exactly.
Yeah. So we will move to, is there anyone still wants to raise the question live before we move on to the chat? Oh, okay. So we'll start with the questions in the chat box. Yeah, there's quite a lot. Okay, the first one from Mas Fatih, is it any possibilities to collaborate your innovation tool in order to adjust with Indonesians, workers maybe?
Yes, yeah, I would love to. I mean, like we would love to have Indonesian collaborators
because as I said, we try to, like, as you see, like most of our collaborators come from Europe. Only one, maybe Turkey, like border between Asia and Europe. But if we could have collaborators from Indonesia, we would love to have it, because then we can see if the model can transport into like different geographic, different background, different, so many differences that we can address if we can validate the model in Indonesian population. But to do that, we will need to have a complete database. What we need is actually like very short database, like these workers at the centers that collaborated with us. They have like we only collected maybe 20 variables, but all workers have to have complete diagnosis, like with or without occupational asthma, and all the variables that are included in the model. If you clinic, or if your hospital, or if your university have this kind of database, we are more than happy to collaborate with you.
Oh,
So currently there's no database in Indonesia, Dr. Eva, is it? I think we have, but separate, like spread out in like, I try to I try to collaborate with FKUI, like with Professor Yunus from Persahabatan. But I think that the challenge is they don't have the diagnostic test. They only have variables for interview. As I said, like methacholine is only like available one for the whole country. So for now, they only have the database for interview, but not with the other diagnostic tests. But we can still like go on, like as I said, we can still validate the questionnaire alone model and see if it works in Indonesian setting. Also, the questions, or like the interview alone so it's only for the validation, right? For the validation stage. Oh, yes, okay. Yeah. So it's, sometimes it's really hard to start. Like we always have a lack of data, lack of database that is really needed for the research. But let's see. Maybe what I can suggest is the easiest is, for example, if you have resident in the pulmonology department, like doing residency, you can have a project to look at the like the occupational asthma, occupational like work-related asthma, and like make it as a resident project. So that way they will collect the data, and I think that's the easiest way to collect data from Indonesia, like from studies like specialty studies or like master studies. Although we don't have like maybe national database or institutional database, but individual like student-based like or resident-based data, I think we can start from there. Is it how many sample like you need at least how many per patient, or how many? Yeah, if we want to validate the model in Indonesia alone, yes, you will need a big data. Yeah, you will need at least, like we developed the model in not too big sample, actually 160. And for example, you go to what apa sih toko roti yang paling terkenal? The most famous
It's like Holland Bakery.
Holland Bakery.
or Sari Roti. Oh, sorry.
Sari Roti. Yeah. I mean, like they have huge fabric, right, in Indonesian factory. So even like from like one company alone, it will be sufficient to validate the model with, if you have like a project like that. Or what else? Fabric Mabel, Mabel.
Oh, yeah.
To wood dust, like take a sample, like as a residential project, like do a project, like evaluate
workers exposed to like wood dust, like in Jepara, for example, we have a lot of people work with
Furniture.
wood carving, right? So actually, there are many things that there's possible to do this kind of things. Is not in a complicated way. Make it as a study, like university-based studies, or something like that.
So it's better we have a small sample, but from a complete in one company like that. Maybe
Yes.
one or two, or similar occupation, like for furniture or company, rather than like there are fats and also furniture company and other bakery is kind of different. So it's better one company but quite complete for the data. Is that correct, or is it like?
So it depends on like I choose bakery because like flour is the most common for high molecular weight agent.
Oh, okay.
And wood dust is one of the most common for the low molecular weight agent. So you have two already groups. Yeah,
okay.
and yeah, it's the most common, like it's the most frequent exposure. And you have big factory in Indonesia.
Yeah.
So it's,
Sure.
so it's if you like, if BRIN could support like studies like that, like university-based study, and I don't think it takes a lot of, maybe like 1 or 2 year to complete, like for a small survey in like Sari Roti or like in like some mebel fabrics, in like Jepara, or like, or in Jakarta also has a lot of in special like spots, something like that.
Okay, so let's have another questions in the chats. Oh, okay. The second questions is about the model. Given the model you develop, what adjustments are necessary to account for differences characteristic between, because it's in Europe population, Europe and Asia, and of course particularly in Indonesia, the adjustment.
Okay, yes, very good question, this one. Yes, I showed you in the slide that, for example, the prevalence that different. I think even like in Canada, we have in our database we have like 50% of the workers referred to our center had occupational asthma. In European like setting, they have 70%. So it depends on like the referral system as well. Like our database was collected in the tertiary hospital, so that's why we have very high prevalence, like 50%. While actually in the general, I think occupational asthma only accounted for about 15 to 25% of the adult onset asthma. So I think in Indonesia, more maybe like we can see more or less the same, like around like 15 to 25, but I don't know exactly the number in Indonesia, but around the world is around that number. So usually what we have to account for is the differences in the prevalence, and what do you call, like the sex differences, maybe also the smoking habit, but it can be done statistically by adjusting the intercept alone. So that's what we did with the European data. So we first did the validation without any adjustment, and then we try to recalibrate the intercept. So it's just done by statistical analysis. We obtain a new intercept for the European data. So that can be done for like Indonesian setting as well. And the last thing is you run the model in European data or Indonesian data, but we just use the same predictor, but we will have different coefficients. Also, this is statistical adjustment. So it's pretty simple actually to do that.
Okay, Dr. The question, Dr. Anton, right? Do you want to follow up, Dr. Anton? Oh, okay. Yeah. So we need adjustment because actually I'm interested with the calculator and wonder if we can test like the calculator. But let's
Oh, the calculator. Yeah, you can test the calculator. You can use the calculator. It's just like when you want to validate the model in Indonesian population. I think you need to have a data set ready for all, for example, like 100 subject or like 200 subject. Already fill out all the online the calculator, like, or the model, and then we can run simple logistic regression to see if the model also work in in Indonesian data. But you can always use the calculator. Like any doctor in Indonesia can now use it, but fortunately, because there are in our online calculator, we also included the 2 diagnostic tests that are not available in Indonesia. So the model might not be good if you run that way. So we can like prepare only interview model for Indonesian population.
okay. Now, do we have another question,
Yeah,
Dr. Sidik?
yeah. I think there are 2 more.
Oh yeah, yeah, Dr. Eva. How long the time that you still have for us because it's already quite late.
Yeah, it's okay
Oh, okay.
because but yeah, the is Isha time here in Montreal is at 11 o'clock.
Oh, 11. No, it's already 11. Yeah.
Yeah. So it's okay. So
Okay.
has there been any research of development of asthma that include work stress or fatigue? Okay. Okay, this is very interesting. I don't think there has been a model including like psychological factor. Yes, because unfortunately, like, psychological factor is the output, like the impact. It's not the causal itself, but it will be interesting to look at. Yeah. Okay. And the last question.
The last
Sorry,
question, please.
given the model,
From
okay, how can predictive model for occupational asthma be tailored to account for diverse occupational exposures and individual susceptibility factor? Okay, another good question. So, so why we develop like high molecular weight and low molecular weight agent? If you can, I don't know, still see the model. I don't know. Maybe Ibu Mieska can can share again the slide. One slide number 18. Yes, okay. Yeah, for this that's why we really split high molecular weight and low molecular weight agent because they're completely different entity. So for the high molecular weight, because the most, like, we have like the question here, agent type, if they're exposed to flower or like enzyme or other. So when they're exposed to, for example, animal allergen, like those who work with the laboratory animal, they're exposed to, for example, rat urinary agent. So for them, they will have a score of 0 because, like, in our model, they're not strong enough. Okay, so it is the flower or enzyme that is strongly like associated with occupational asthma. But when you look at the next slide, the next row here, the sensitization, the work-specific agent, it's also like reflecting maybe the type of agent, because people who work with the laboratory animal, like they also have a strong reaction to like specific sensitization. So although they might not have like flower, they might not be exposed to flower, but if they have positive sensitization, then they will have score 2, like even higher, like 100 point. If you have positive like SPT, skin prick test, sensitization to specific workplace
I
agent.
like it.
Yeah, so that's why this model have already like we developed with so many trials, and this is the best model that we could have. The first 1, 2, 3, 4, the first 4 items are from the questionnaire, and the other 2 are from the testing.
Oh, okay. So it's a combination of questionnaires and testing, but for Indonesian cases, if we want to try or to validate, we can do only for the questionnaires only, for the interview only. Okay,
Yes,
I
yeah.
saw that someone raised his hand. Handy, is that? I saw that Handy is already. Oh no, Bapak Handy, do you want to raise question? Oh, if not, let's move to. I think we still have another one questions in the chat box. Yeah. The last one from Pak Riswal. Oh, we still have 2 more. Okay. From Pak Riswal. It's about mathematical model. Oh, still have more. Okay.
Great. Okay. Indication for asthma
Yeah,
only so
model.
this is indication for asthma patient.
It's yeah, maybe the model is like a mathematical model, or what's the difference between like under what's the under area curve and with, is that mathematical model, other mathematical model, or how to develop other model? Yeah.
Okay, yeah, I'm like, so if, for example, if I understand correctly, the question is if you want to develop a model for only for asthma, if you want to like diagnose just asthma, not asthma like work-related asthma, you can also develop a diagnostic model. I'm not sure if they're, because it's not in my field, like although this is like also asthma, but I'm more specific like work-related asthma. I'm not familiar if they have a special model for asthma alone. But I think Gina already has like some criteria to diagnose like asthma, to establish a diagnosis of asthma. And I think it's based on the same thing like study with logistic regression, multivariate logistic regression, to see like what are the most strongest like factors or like symptoms that are associated with the diagnosis of asthma. Yeah, it can be like the symptom, like if you have what do you call shortness of breath when you're like walking, or if you have like asthma attack, like in the past 12 years, or even like if you have like smoking habit. I think all those information are like important factors related to the presence of asthma. But I'm sure like Gina, like the association, international association, already have some criteria for diagnosing asthma alone, not occupational asthma, but asthma alone. But if you like want to develop a new model for any disease, like not necessarily occupational asthma or asthma, you can always use a mathematical model like logistic regression, but you need to have a good like definition, a good outcome, like a golden
Standard.
outcome with the golden diagnostic like result. Gold diagnostic test, or I mean like gold diagnostic test.
Yes.
You need to have like a proper sample size. You need to have like complete data set. If you have all that, yeah, you can develop the model with statistical analysis.
Okay.
Yeah.
Okay, so that is Pak Rizwal, answer
the
Pak
last
Rizwal's question. And the last one, there
I
is
don't
one
see
more.
the questions.
Yeah, this is the last one, I think.
Given the model you develop,
No,
yeah.
you
Okay,
share
this one. Okay.
from Dr. Sidik, yeah.
Mhm.
XM, XQMXD.
Oh, okay. Yes, yeah. So actually, if you have a model and you want to translate into online calculator, the QXMD is a company based in Vancouver, Canada. So they could help you to transform your final logistic model into an online calculator for free. So that's what we did actually. Like at the time, we didn't have any funding to develop an online calculator, but to publish such calculator, your model should be first internally validated or externally validated. So it's like for sure it's a valid model before it can be transformed into an online calculator. Once you have a valid model, then you can approach them. I think like at the time I just like emailed them saying that we already published our model, we already published our validation study, and we want to transform our model into a calculator. And it's pretty straightforward process. They only ask so the final logistic regression equation, the legend, because you need to code them, right? You need to code, like, for example, if like the subject answer this and it will give the score of what and so on and so forth. So we give that detail answer, and then also the consequence. You need to have a cutoff and also the subsequent action, because for online calculator, after you calculate the sum, you need to have like action. So that's why you need to have you need to choose your cutoff wisely, and also what the subsequent action. Once you have all that, you can contact them and they will be happy to help you, and it's for free. In my experience, we didn't pay them anything, because I think they have partners with like hospitals, where they have funding to run their website, and in return they also help like researchers who doesn't have a lot of funding to publish their online calculator. So that's how they do it.
Oh, sounds interesting. Or like helping with the model to be a calculator, and then also have help with the publications. I think there will be many researchers interested in that part. Okay, yeah, I think that was the last questions, and yeah, I also think that this is quite comprehensive. That's very specific on occupational asthma. That we also should try, because we have maybe similar or maybe worse condition in Indonesia for the
Yes,
workers.
yeah,
We have like a lot of Gojeks, yeah, who
exactly.
are exposed to the dust or any kind of allergens every day. Maybe we will be very specific, like the occupational asthma in the Gojek drivers or Grab drivers or ojek pangkalan drivers. That will be interesting. But before closing this, just would like to highlight a little bit about the last research, the Survei Kesehatan Indonesia survey, the 2023, Dr. Eva, that the prevalence of asthma in Indonesia in general population, of course, is 1.6%. And
Okay.
yeah, and for the age category, the highest percentage is in those 65 to 74 years, 3.2%, and female slightly higher, 1.8 compared to 1.5. And if it's about the occupations, maybe because this is not quite specific, but the highest prevalence are in those who are not working, is 2.1, and compare with others like 1.8 in the government employees. Because maybe the category of not working is not really specific, but it's said like the highest prevalence are in those who are not working. Maybe that.
So these are the occupational asthma data?
No, it's all general populations, but
okay,
yes,
asthma in general
but
population. Okay.
yes, but based on the occupations, the highest prevalence are in those who are not working category.
Okay.
Yeah.
Okay. Yeah, maybe there
Okay.
because like one of the exposure is also like cleaning products.
Oh, okay.
Yeah, if you use cleaning products or maybe they're doing in the wrong way, they're exposed to, but yeah, it's interesting. Like a lot of them are not working, or maybe they stop working because they have some asthma. Could be.
Yeah, could be. So that would be interesting. Maybe any of you, the researcher in BRIN, wants to analyze further with this data and work with Dr. Eva about that. Maybe that could be a manuscript later, because the data of the SKI in the 2023 has already opened for public for analysis. So prepare for it, I think, yeah, researchers in BRIN. Okay.
Yes.
Oh, that was, yeah. I think from the first time I read your slide, I already interested in this topic, especially like the models and the calculators, and I just wonder how can we use it later. So thank you, Dr. Eva, for your presentations, and this is your e-certificate. Eva Suartana, MD, PhD. Thank you very much for your valuable contribution in these seminars. And I hope that we can collaborate and later in other activities. Maybe if one of our researchers also interesting to collaborate with you on, and yeah, with some other areas.
Yeah, with pleasure.
Yeah, good night, Dr. Eva. I think it's quite late there in Montreal.
Yes.
Thank
Yes,
you.
this is I put in the chat box my email address if you need it. Okay.
Okay. That
Thank
would
you.
be great.
Thank you for having me. Bye.
Yeah, thank you, and see you later in our next
Bye.
activity. Yeah. Okay. Oh, yeah, it's quite late. But we will have our last speakers, Anthony Paulos Sunjaya, MD, PhD, SM, MSc, Internal Med, Edin. He's a research fellow in the Respiratory and Health System Science, the George Institute for Global Health, the UNSW Sydney, consultant of clinical engagement in the Cherry Institute of Health Engineering, also in the UNSW. He is also Honorary Research Fellow in the School of Public Health, Imperial College London, and visiting researchers in the Royal Brompton and Hartfield Hospital, London. He gains his medical doctor degree from Tarumanagara University, Indonesia, MSc in Internal Medicine from University of Edinburgh in UK, and PhD in Global Health from the George Institute for Global Health, UNSW, Sydney, Australia. Yeah, he's just graduated this year in a very young age. And his last publication is about the health and economic burden of breathlessness in Australia, and also acceptability and visibility of chronic breathlessness diagnostic clinical algorithm in Australian primary care. Yeah, since Dr. Anthony is having another concurrent activity, so he already prepared his presentation in video recordings, and hopefully he will join us later after the presentations. So please share the video. Thank you.
Good morning. I would like to start by thanking Professor Indi, Dr. Harimat, and our moderator for today, Bu Yuyun, for the invitation to allow me to share regarding how co-design, implementation, and evaluation of digital health and clinical AI tools can improve outcomes for patients with non-communicable diseases. A bit about myself. I'm Anthony Sunjaya, and my research focuses on improving outcomes for patients with cardiovascular diseases, respiratory conditions, diabetes, especially in primary care. I leverage digital health and clinical AI tools, as well as use methods including clinical trials, influencing health policy, and health management approaches to do this. I'm currently based at UNSW Sydney, at the George Institute for Global Health, and also at the Tari Institute for Health Engineering, with honorary appointments at Imperial College London, and I'm also Associate Editor for AI and Digital Health at the Annals of Family Medicine, among my other professional representations. As a quick introduction to my two main affiliations, the George Institute is Australia's #1 medical research institute, whereas UNSW Sydney is currently ranked 19 globally with over 60,000 students from 132 countries. And we do cutting-edge research, among others, on digital health and medicine. Before I begin, I would just like to start by some disclosures and acknowledgements. Many of the projects presented today have been presented in other international meetings and have been funded by a variety of sources, including Australia's Medical Research Future Fund and other grant bodies named here. A number of the sections are unpublished, so I would like to ask, where possible, to refrain from presenting or sharing the results beyond the current audience till the final papers been published. And the views presented today do not represent any of the groups I'm affiliated with. This is an overview of today's presentation. I'll discuss briefly 5 projects that I've been involved in the digital health and clinical AI space. We're starting with looking at electronic resources and digital apps, then looking at data, which is the bedrock or foundation of many of the things that we do, including in AI, looking at interoperability as they are an important component to which many of the tools, including decision support systems, which is my specialty, and other technologies such as mobile apps will be connected with each other. And then move on to a large study that I'm part of and principal investigator on co-designing and then trialing clinical decision support tools for breathlessness, a multi-morbid condition that I shall describe further later. And then I'll also discuss the validation and trial of AI spirometry interpretation software funded by NHSAI in the UK. I'll briefly then touch upon, before I close, other ongoing projects that I have in the works, and I'm happy to discuss them more and also to explore opportunities to collaborate and do similar stuff in Indonesia. I'll start with this first project, where I had been interested to explore with the vast amounts of digital resources, be it blogs, but also importantly, health pamphlets and pages, as well as mobile apps, thousands of them in the App Store today, how they might impact patient care, and importantly, what's their quality. So, for example, we explored in this study what's the effectiveness and quality of those materials, especially relating to breathlessness. Breathlessness itself can be caused by a variety of conditions, including asthma, heart failure, obstructive lung disease, but also things like psychogenic causes, as well as obesity. So we look at resources focusing on these major conditions. We identified about 90 of them and found less than 15% to be of high quality, and only one suitable for those with low health literacy, meaning less than grade 5, which is very pertinent to Indonesia's condition with our high proportion of the population still having only primary school or middle school education. Effectiveness-wise, we only find 6 studies showing any results regarding this. They all reported improvements post-intervention, noting that for many studies, they're only pre-post design. But interestingly, we did find one study which showed a significant reduction in ED and hospital admissions through an RCT of a COPD manual that encompasses not only physical, but also the mental impacts of the condition. So there's hope that we can do well for patients if we use it well. Effectiveness and quality-wise, we also compared readability across the different disease groups as shown here. As we can see in this slide, some conditions, like asthma especially, are doing very well. They are reasonably written and are understandable with the average readability level of grade 8, which is the minimum standard for these type of resources. But at the same time, we can see for conditions like heart failure, a substantial proportion of them have very high readability grades, meaning that people need to often be high school completers or university graduates to be able to understand them, something that's not acceptable, especially noting that in many places, including Indonesia, most people wouldn't have that sort of education. I also look at then with the team, what's the impact of mobile apps? Because they are now a mainstay of many settings, including starting to grow in Indonesia. We know that self-management can help in patients with breathlessness, and that apps, when used well and developed properly, can help scale this impact. But there are thousands of them out there. My systematic review found only 16 studies reporting in any way, any design, what's their impact. They did suggest that apps can improve and support better home testing through the use of point-of-care devices linked to those apps. But there's variable results on efficacy and mostly high risk of bites, showing more work needs to be done. On the other hand, we also use a number of frameworks to assess their quality. We found only 6 apps publicly available to assess, and a mean quality rating of 3.4 out of 5. So not too bad, but importantly, also found that no apps were fully compliant with the Health on the Net code, which is a principle that has been made regarding to determine what's a high quality mobile app. For many, they fail on aspects regarding especially data privacy and cybersecurity. Very important, especially with the recent news that we can all hear of from Indonesia. Across a small number of studies that we can pull, we then conducted a meta-analysis. Unfortunately, it's difficult to conclude owing to the small number of studies. Today show trends for some level of improvement. On the right, we can see the mobile app rating scale scores for a number of the apps that we can assess. For many, for example, we can see good functionality, a number of them have good aesthetics, but the issues we found mainly pertain to the information that they contain, which is the most crucial thing, arguably, because they are the ones that would likely very much impact whether an app works or doesn't work, beyond only the bells and whistles. Next, I'll discuss a study where we look into the recording of social determinants of health data across EHRs in 9 countries. This was an invited study by the International Medical Informatics Association for their annual yearbook, where they present results of the state-of-the-art research happening in the health informatics space around the world across the past year. Why social determinants of health, some may say? 80 to 90% of health outcomes have been shown to relate to social determinants of health, summarized in these 5 measures on the right. They are especially important in the current interest to have more precision and personalized medicine delivered to individuals, but also at the population level. And these mean that we not only need to understand genetic factors, which are important, but also epigenetic, lifestyle, social, community, and environmental factors surrounding the individual, which are encompassed by this measure. EHRs found a foundational tool to record many of these details, and also importantly, allow for them to be acted upon. Non-recording of them, or poor quality, I would say implies that they're either not of interest or not in use, which means that patients are detrimentally affected, unfortunately. In brief, this study aims to report the national taxonomies for social determinants of health to look at whether there is any similarities and harmonization that can be done, report on the quality of recording of many of these indicators, and make recommendations on how we can improve the quality of those recording. We combine a group representing member states from across the world, across most of the continents. Unfortunately, we don't have enough data from Indonesia to report on this one, but I'm very interested to explore doing more in this space with data from Indonesia, especially with the growing data set that's present through Satu Sehat and other entities. We utilize a standardized data collection form and focuses on these measures, acknowledging that these are measures that probably are the most relevant to day-to-day practice and what would most likely be present because of these practical uses. They include age, gender, ethnicity, but then measures as well relating to occupation, education, smoking, and other factors. These are some of the results. I'm unable to present the whole of it because it's unpublished, but we can see here in general that for some measures such as age, gender, rurality, regionality, many of these presented by postcodes, for the last 2, we have quite decent recording and 100% in many settings. But if we go down and go towards other details such as socioeconomic status, income, accommodation, residential care, education levels, we can see they start to go down south. Education is especially of interest to me, for example, because as we are aware, people with higher literacy do have better outcomes. And those with lower literacy are those that needs more support. This means that not recording means that we're not fully aware at times on what people's educational levels are, which means that we cannot tailor the messages we present and also inform policy for the development of more resources that cater to this low literacy group, as we can see earlier from the digital resources we've assessed. Obesity is better recorded, mental health and smoking as well, which is good to see. I'll move on next to our other study, looking at global use of FHIR interoperability standards. And FHIR might be something that's more commonly heard in Indonesia these days, again with Satu Sehat using it as the basis for interoperability. Why is FHIR important? Certainly, one use case in Indonesia is because of the data collection, but around the world, it's increasingly being adopted for healthcare data exchange. It is part of an act in the United States where entities are mandated to use FHIR to gain Medicare funding. But as a whole, it is important to have many of these resources talk to each other. And to do so, there needs to be a standard framework. And FHIR is the current standard that a lot of countries have chosen and is supported, among others because it's free to use, as we can show on the right, and a number of other benefits. The study that I'm presenting aimed to provide a preliminary assessment of how FHIR is used in the real world setting, so not in development, but in the real world, to provide use cases for people to replicate and learn from. These are some of the findings. More details can be seen on the published paper. If you search for my name and FHIR and JMIA Open, you'll be able to access it. So we looked into and reached out to over 1,000 FHIR app developers to find out what actually is the state of the art at the time and what's actually in place, often not published. Often some of these details are presented in technical reports and internal documents. And we found 112 of them in the end. We can see here, depending on the type of their use, it can be for clinical care, for research purposes, to support population health, health information exchange, administration, or other use cases. There's difference in organizations that develop them, as well as the health domain, the diseases that becomes the focus. Of interest as well is the target audience. And it's good to see that a large number of them do focus on patients as well. And we are interested as well to explore at a more technical level what FHIR resources are in use. Some of it presented here, for example, relates to patient details, condition details, which are expected because for many of these cases, they're used in clinical care. We also explored the terminologies used. ICD-10 is quite common. This is the same one that's, I would argue, is used in Indonesia as well in practice, but also LOIN codes, SNOMED codes, and others. And this is especially of interest probably to the partners for this study, including those at Indiana University, which develop actually LOIN codes at the Regenstrief Institute, but also colleagues that I work with at Stanford and the Department of Veteran Affairs, for example, which utilize this to develop frameworks to allow for scalable mobile apps to be developed easier. I will also describe here a bit regarding some of the more technical details regarding the APIs used and the presence of CDS hooks. CDS hooks is a standard that allows for information exchange, especially to web interfaces, and this is commonly used for many purposes, one of which is when we integrate CDSS or decision support tools into electronic health records. And if we see here, there's a range of development stages. Some are in real-world use, but at a pilot stage. But for many, which is what we're mostly interested in, they are used in multiple sites, which is great to see. And other details presented here for viewing. Importantly, I suppose this study showed that certainly there are data available, and we've provided this now publicly for people to reanalyze and to be able to reach out directly to those use case developers. But there are still challenges. We found great difficulty in even being able to access this level of detail for many of these apps, meaning there's a need for existing repositories and policies to provide more registries, for example, supporting recording of these use cases so that we can learn from them and transfer learnings faster, similar to how we register clinical trials or systematic reviews today. And there's also a need to use that to foster a more vibrant community of FHIR implementers globally, because there's a few number of them around the world, though it's increasing in number. I would move on to describe a larger body of work that's taken place across the past 5 years, where we aim to co-design and trial clinical decision support tools for breathlessness, especially in the Australian setting. That we're increasingly looking to implement this as well in other places, including Indonesia. As a start, I'll introduce everyone to the design thinking framework. Some of you might be aware of different types of frameworks similar to this. Many of them are popularized by the Stanford D School, but essentially it involves 6 stages to develop through this co-design process. One is to empathize with the end users. In this case, many of them would be GPs, primary care practitioners essentially, and also the patients and their carers. Then to learn from them and define what actually are the needs, what's the requirement. From there, to ideate possible solutions, develop concepts on what things need to include, then prototype to start testing. Along these stages, if there's any doubt at all, we can step back and also re-inquire, reconvene groups of end users, and iteratively discuss with them what needs to be present in the end result or a prototype at the start. Then from there, test that, in this case for us, through a think aloud process, but there are also other methods to use before implementing at scale. And for this one that I'll describe, in a trial in 40 general practices throughout Australia. So why breathlessness, some might argue? This is Australian data that we've analyzed based on the National Breathlessness Survey conducted across 2019 and repeated in 2020, where we recruited a representative sample of about 10,000 Australians to look at what's the prevalence of breathlessness. I would note in 2019, this was recruited before COVID was known, whereas in 2020, this was in the middle of the pandemic, which might impact some of these numbers. But in general, we can see that about 9 to 10% of Australians have breathlessness, which impacts their activity, and that those with breathlessness have twice the higher odds of a visit to a GP specialist or the emergency department, 1.5 odds of hospitalization, and twice the odds of productivity loss from work, but also from not being able to attend school. We also found significant reductions in quality of life of about 8% And this is important because this is similar to many cancers, including breast cancer, and it costs the system over $11 billion each year in healthcare costs and far greater in indirect costs as well. So this is a problem, and I would say this is not only a problem in Australia, but in many countries around the world. So we explored then, knowing this problem at an epidemiological level, what's on the ground. With patients, we've worked with them and carers to determine where actually are the points for intervention. One of the points for intervention we identified is a lack of knowledge. Certainly from the patients and the carers on knowing that breathlessness is important to intervene on, but also from the providers that they meet, which were said to have dismissed their claims or taken a long time to work out what's their cause, use diagnostic tests and interpret them, or refer them when needed. So there's a need for more resources to support this too. Whereas GPs, but also specialists, see a variety of other points. Certainly, some of them relate to patients not being aware, but also the large volume of guidelines, noting that breathlessness can be caused by heart disease, lung disease, but also lifestyle and psychogenic causes. And often they don't present alone, but they're present together. And this is a problem. Multimorbidity is growing, and most patients with breathlessness, about 60% of them, will have multimorbidity. And this is not covered in many guidelines we have today. So there's a gap, a practice gap to fill there. Certainly funding is a problem, as well as access to appropriate referrals, and also how silent medicine often delays care. Some suggestions were presented below, among others, that a clinical decision support system integrating these features where you can manage multimorbidity and support assessment for GPs, as well as help screen patients, can be of benefit. So, as we are aware, breathlessness can be caused by a number of causes. A large number of them are heart and lung diseases, but we cannot tackle all of them. So in this case, we utilize an existing resource from NPS MedicineWise, which collates data from 405 GP practices, which we then analyze. We found a number of important causes, such as coronary heart disease, lower respiratory tract infection, asthma, heart failure, and then compare that with our findings from the National Breathlessness Survey to find out what's actually the top causes that we need to focus on at this first stage. We've also done quite a lot of work to develop and identify frameworks for the assessment of breathlessness that's relevant for the primary care setting. On the left is one that we've published in Respiratory Medicine Today that's distributed to over 80% of GPs in Australia. And on the right is a desktop helper that I was part of, developed with the International Primary Care Respiratory Group and distributed globally, with translations being made in a number of commonly used languages. And it's really accessible via the QR code presented below it. We developed also a pathway, or what we would say a diagnostic algorithm, representing what's the main test and the possible yields when they're then in sequence or together to assess those with chronic breathlessness. And as well as on the right, just an example of our approach to develop a Bayesian network model that's done through machine learning based on data sets from the UK, where we were able to access a subset of over 7 million patients with breathlessness as their presentation. It's a proprietary model, so I can't present everything here, but we have developed them and showed, though it's unpublished, and we are able to achieve high AUC levels of 0.8 to even 0.9 for many of the conditions of interest. Beyond certainly making it possible to develop or having it technically present available, it's important to see whether many of these pathways are feasible to implement, especially in the Australian setting, but similar work needs to be done when, for example, we adapt this for the Indonesian setting. We managed to do consensus studies with GPs to look at whether these diagnostic tests are commonly done or would be top of mind, for example, for them, and compare that with what we have in our evidence-based pathway. But then we also analyze the databases of GP EHR data to explore what actually they do. And we do see a dissonance. For example, many would put, I would say, spirometry as one of the main diagnostic tests for those with lung disease to assess their lung function, but in practice, a very small proportion do them. And we found that for many with asthma, for example, and COPD, about 30% of them only have the test done in the past 10 years, with which we have data for. So it's a big issue still in Australia that we want to improve on. We also look at existing literature to see whether there's existing tools that we can adapt, as we do not want to duplicate. We saw that there is evidence that clinical decision support systems can improve outcomes for those with heart disease, but also with asthma, for example. But we also see that most are disease specific. But as we're aware, patients increasingly, and for this particular condition, will present with multimorbidity. So many of these tools wouldn't be very useful. Many focus on management because that's probably where you can see directly the outcomes. But we're interested in assessment because that's where we see most of the gaps are reported and where there's evidence that there's a knowledge gap in the primary care setting. We also explored other outcomes by disease, on health economic impacts, on patients' providers, unintended consequences. We found them to be safe despite what we found, though many of them are reported by GPs to present references or recommendations that's not personalized, that's not relevant to the patient in front of them, among others because they don't account for the comorbid conditions that they have, something that we want to improve on. We then developed mock-ups and did virtual testing because this was during COVID. This is an early mock-up that we developed. And mock-ups can be done in this way for those interested in digital development at the start, because this allows us to iterate quickly. And with a small number of end users, we are able to identify most issues upfront and then improve on them and grow with them. So, for example, here at the second round, we are able to show that most users, most GPs that's tested upon, enjoys using it and feels that there is benefit in the clear quantitative information, though there are questions regarding how the learning curve to be able to use it well. And this is the current design that we have after a number of further testing. And while we want the interface to be as simple as possible, a lot of the work has come into integrating how data from the electronic health records themselves can inform the probabilistic algorithm, but also collecting data from patients, including screening them in a waiting room at home, and enhancing the results presented with minimal input from GPs as shown here. This has now been funded for a pragmatic open label cluster randomized trial in 40 practice services in urban and rural Australia over the next 12 months. We're starting this trial later this year, about September, and we aim to recruit about 400 patients for this trial, but at the same time, screen a wider pool of 12,000 Australians to enter into the study. Our primary outcome is change in breathlessness levels as ascertained by the DIPSNIAN-12 measure, but we will also look at other measures of disease control, practice impact, impact on quality of life, and also importantly, cost effectiveness to support scaling it at a national level even further. I will then describe the last project for today, which is the validation and trial of AI spirometry interpretation software funded by NHS-AI. And this is work that I've continued to work on across the past 2 years, for the most part, with colleagues at Imperial College London and the Royal Brompton and Hatfield Hospitals, among others. So, as we know, spirometry is a measure of lung function. It's especially useful as a gold standard diagnosis for COPD, obstructive lung disease, certainly, and also conditions like asthma. However, as we know, AI can ascertain patterns from signals, in this case, flow volume curves from spirometry readings, to predict a variety of number of things that we probably cannot see from our own interpretation. In this case, we utilized an existing CE-approved AI spirometry tool that's not used in the UK though, to see whether it is possible to implement in a primary care setting, because it was originally developed in a secondary care setting. As we see here, this is one exemplar output from the software. We can see that it will provide probabilities for quantitatively for conditions like asthma, COPD, other obstructive disease, and other conditions, and then provide a conclusion to support GPs or other practitioners to ascertain the cause. However, before wide-scale implementation, NHS and ourselves are interested to see whether this actually works. This is very important from a quality and safety perspective. And so what we did was we compared quality assessment that they do against respiratory physiologists. So even before predicting the causes or possible causes for someone presenting and having the spirometry done, we want to see whether they can compare and ascertain if this a good quality measure or a poor quality one which you shouldn't be implementing or interpreting. As we're aware, garbage in, garbage out. When that's done, we also, in parallel, are looking at whether diagnosis probabilities presented concur with those of respiratory specialists. In this case, experts that will have full access to clinical notes, longitudinally, and CT scan results, as well as other measures. Certainly, this meant that actually the AI is at a disadvantage. But at the same time, if it works in this setting, we strongly believe that it means that even if it's mildly inferior, it will still be beneficial. And then outside of that, we did an RCT called Spiro8, where we want to assess whether GP's interpretation of spirometry are impacted by the presence of AI decision support, and outcomes of interest include accuracy, time to assess. This is important in the clinical AI space, because as we know, GPs and health professionals in general have inertia, clinical judgment inertia, where it's difficult to influence what they have already set in their minds based on the patient's presentation, which goes beyond certain objective measures and numbers. However, these meant that if we implement AI tools, some of them could be far superior to experts or are equal in results to senior experts or a panel of experts, which is better than certainly one health professional that's assessing something at the same time. They might mean that we are actually, when implementing such tools that are superior, creating a safety risk if GPs are not sufficiently considering those outputs and hold on to this inertia and not change their behaviors. So this is a bit of looking at clinical behavior, but also see what's the actual potential real-world impacts when implemented, because inertia would certainly play a role in minimizing any of the impacts from the accuracy or superiority, if any, of AI tools. The validation results are yet to be, I would say, presented openly in the public, so I cannot present it here, but they have been accepted and will be presented at the ERS Congress later in September in Vienna, Austria. So stay tuned, and the paper is also currently under review. Spiral rate results from the RCT are also under analysis, but I can show here that we have been able to recruit over 200 primary care practitioners in the UK from around the country to participate and randomize them into two arms. There's quite a number of them that are non-completers, so they are balanced across both groups. And this is, I would say, expected from the virtual nature of this trial. We do want this to be fully remote, and we want to have minimal guidance from ourselves so that we can really see what's the impact in real-world practice. And also stay tuned for these results. We're finalizing analysis and have the database locked in a number of weeks ago. So we'll be able to see the results shortly. I'm also currently involved in a number of other projects on digital health and AI, including with the European Respiratory Society Clinical Research Collaboration, a group of 400 partners essentially working together, and I'm working on one of their work packages looking at real-world implementations of respiratory digital health. I'm also involved as part of the panel for the chart reporting guidelines for chatbot LLM studies led by colleagues at McMaster University in Canada, part of the WONCA committee looking at the ICPC, or the, I would say, standard for reporting of primary care conditions similar to ICD-10, for example. I also am involved with the Digital Health Self-Management white paper due to be published soon by the International Society for Telemedicine and eHealth. Have some I would say, work initiated in using AI to enhance digital stethoscopes, as well as to develop prediction models for early detection of NCDs, especially COPD, that's of interest to the group. That's all I have time for to share today, but I'm happy to discuss and answer any questions that you might have on this. Please feel free to email me as well following this webinar for any discussions.
Okay. Let's see. I think Dr. Anthony has already joined us. Fortunately, yeah. I believe that the last presentation is a very hot button issue. So, yeah, I think the audience maybe have the burning questions in their minds. And welcome, Anthony. How are you?
I've been good, thank you. Hope everyone
Okay.
had a wonderful morning.
Yeah, exactly. Wonderful morning. And are you in Jakarta now? Or
Yes, currently so, having a number of meetings, unfortunately. But yeah,
okay.
great to
Okay,
see
okay.
everyone.
Yeah. So thank you that you made it on time joining us. Okay, this is the Q&A sessions. I wonder if anyone wants to raise the questions live. Okay, please. We still have around 120 participants, which is good because it's already 3 hours seminars. Okay. But while waiting for the live questions, would you please, Dr. Sidik, show the Q&A in the chat, or we also have the YouTube live stream, so maybe there are questions in YouTube. Okay, because this is a hot topic, talking about AI, of course. Yeah, the first question from Mr. Mas Pati is about the data privacy and security, especially in the current trends in Indonesia. As you know, that we have the data leakage hack recently. Yeah. Okay, please, Anthony.
Sure. I think there's various ways to see this, right? Certainly improving risk management as a whole is important. I think that's the work not only of the government, but of everyone in the sector. But outside of that, there are advancements in the technology. Lots of AI now can be done on the edge, we would say. So not really pushing data to the cloud or any identifiable data to the cloud, but really doing edge computing to advanced microchips, small microchips, and using not, for example, large language models, but what we call SLMs, or smaller language models. In this case, no exchange of data needs to be provided to a centralized service. And that's where the risk is, right? For example, the recent occurring in Indonesia. So how we can decentralize processing for some of the digital health AI use cases, I think is one way to enhance privacy and security till we reach a point, for example, when we can fully trust or we can fully be sure of the security of centralized services. And at the same time as well, I think for Indonesia, outside of security and safety, is also accessibility. Internet certainly is getting more accessible. Bandwidth is getting better. At the same time, for routine services, any lag shouldn't be acceptable. And this is also where edge computing cases, not only being secure, can improve accessibility in practice. So that's one way, I suppose. There are many ways for sure to make it more secure, to improve privacy. But one way to do it is if you just process it at the edge, essentially, in your phone, in a device, and etc.
Do you want to follow up, Mas Pati? No? Where is he? Okay. Okay, let's move to the second question from Mas Haikal. I think it's still talking about the same safety issues, like compliance on standard and guidelines. Like, it is the Indonesian government readiness. Yeah.
So I think there's been improvements. I'm aware and to, I would say, engage, for example, the Digital Transformation Office at the Ministry. It's done a lot of work in this. I think a lot of, outside of only having the guidelines, I would say, is really compliance, right, and enforcement of these. I think in time, there will need to be a move. And this is also a problem, I would note, not only in Asia, but even in Australia, in the US, of how we need to arguably police, like we do for drugs and medical devices, many of these digital health and AI technologies that people can access, be it in app stores or in the market, against certain standards. And these standards can be the ISO standards, for example, but certainly locally driven standards as well. And building the awareness for users that not to use services or technologies which don't have a certain accreditation, as I think people have understood for drugs, for example. I don't think people will consume medications that don't have an approval, for example, from the FDA. Why should people do the same for digital health, and especially more advanced AI technologies that impact their behaviors or predict what, for example, drugs they need to provide or what diagnosis people have, as we are doing, for example, in Australia. So I think that is where I think there's an awareness piece from the community, but there will also need to be some policing. And to do that well, we do have to have clear standards, clear regulatory bodies that will assess those tools. And I think it's a moving field.
Okay, wait. Is there? Okay. What's another question? Is there still? Oh, okay. This is about challenge when integrating digital health and AI tools into. Oh, yeah, this is the challenge in the existing healthcare system.
It's a very interesting question. And I think I would say this is generalizable to many integrations, so not only for breathlessness, but in our case, one big thing that we want to do is integrate with existing workflows, meaning it needs to integrate to electronic health record systems. And often, and for most of them, there are proprietary systems owned by commercial entities. So they're not open source. We cannot, for example, often directly access them and need third parties or partners or approvals from them to even access a small bit of data. And that's the biggest challenge with integration, because until very recently, we don't have common standards. And that's where FHIR comes in, as I had presented a bit earlier, where having a common standard, hopefully, so today that's the challenge, but hopefully tomorrow, if there is a common standard, even if you have different devices or EHRs that you want to connect with, you know that they need to code it a certain way or close to a certain way. And that makes things very much easier because you don't really need to ask them. Maybe you can prepare it, you can just adapt it a bit when you want to integrate. For example, now though, we need to do the reverse. We are reliant on those companies, so third parties, to help us integrate because they are the ones that have the full access to the electronic health records. That's the bedrock of many health systems today. So maybe that's one big challenge, I would say. I see.
Yeah. Just to follow up a little bit about the electronic health EHR. I think as you know, maybe Indonesia has already have some EHR, of course, like in the BPJS Kesehatan or in Satu Sehat, or we previously have the Peduli Lindungi or something. So in your opinion, what are the AHR or the application that can be developed or can be harnessed for further research or further diagnosis, something in Indonesia? Which one do you think?
Sure. Maybe I will clarify a bit. I think Satu Sehat is a data integrator. It ends up being a data lake. It's not an electronic health record, but it's fed by many electronic health record systems in Indonesia. So it's not an EHR on its own. Whereas Peduli Lindungi, arguably, is not an EHR, but maybe closer, if any, to the most recent version, a PHR, right? A personalized health record. Integrates only for the particular individual. So it's not exactly an EHR. EHRs are those used in hospitals, for example, or in the primary care facilities, right? Whereas the one by BPJS, I wouldn't also exactly say fully as an EHR because the PCare system, for example, is more of a reimbursement pathway, right? It's a reimbursement system focused on that, not really on maintaining longitudinal records. And that's in some ways what we need. And what Satu Sehat is trying to do, right? They're merging records from every electronic health record that is from a health facility to link those for a patient. And in time, I would say the biggest barrier is data quality today. I think, while I don't have data from Indonesia, for example, for the social determinants of health study, but I think we can predict that for many, we would have similar issues on data quality and completeness. And that's an issue because if we can develop predictive models, if there is the data, with the team, I would say we can develop predictive models. But will the models be accurate when the labels are not, right? Will the models be useful if they are biased to certain cohorts or only certain groups being the one with complete data? I think those are the challenges. I think we're in the nascent phase, but I see in the next 5 years, actually, we're going to be able to lead because this data now is flowing, and the data lake that we will have at the population level, if with good data quality and completeness, I think will allow us to make national specific predictive models, to not really use any more prediction models like I think discussed, for example, by Dr. Eva, right, the previous speaker. So not really use global models, but for example, like what she's doing in Canada, develop ones with local data, with local setting. You can validate in similar settings, for example, maybe for us in the Southeast Asian context, but we really are developing this from the data in the population itself. But to do that, we need good data, high quality data, and data completeness. And maybe as a start, even if we're not at the population level, we need to have centers that do that well and use that as the seed, right, to develop these models to then scale and revalidate in a wider cohort as we improve quality.
Okay, I see. Yeah, I think that's another challenge. Okay, is there still any more questions? Okay, from Dr. Ahmad, how can digital health and AI tools be seamlessly integrated into existing healthcare system without disrupting current workflows or creating additional burdens for healthcare providers? I think this is clear, right? Because, you know, in the Puskesmas, there's a lot of applications. I think Kemenkes has more than 200 or something, if I'm not mistaken. Maybe you can answer this.
Sure. I think it starts with approaching it through a human-centered design approach, right? I think one of the biggest issues that everyone now realize or have been realizing across probably the past 5-10 years is we have a lot of digital health softwares, right? And technologies in place. Many of them developed because of interest or because of things that seem flashy and nice, not really because of an unmet need. And I think stepping back and coming back from that perspective is important. Really thinking about what's actually the gap, unmet need, for example, in Puskesmas, right? Looking at what's actually being done today, where is the gap, right? Is the gap being, you know, we need a lot of papers just to do a laboratory test or to refer patients to other settings? Is the gap, for example, with inventory? Is the gap with other things? And it can be simple stuff like that. And then not really designing the solution first, but ideally looking from there, determining the requirements. What are the functional, non-functional requirements? What does an ideal solution to solve it, but still fit to the current workflow? Or if not, enhance the current workflow, shorten the workflow. That's fine, right? Extending the workflow is an issue, but shortening the workflow is great. So thinking about it that way, then looking at existing solutions for sure, or designing new ones, but not stepping backwards and saying that, oh, I have this flashy software, I want to implement it in a hospital, I want to implement it in the Puskesmas, and thinking about how do I fit it in somehow, even if it extends or adds to the current workload. Because I'm aware, I think, as health professionals in Indonesia and also Australia, people are under a lot of pressure to deliver care for patients, and that's what we want, right? Improve outcomes for them. And I think it will be a disservice to think about using digital technologies to burden them even further, which arguably some would say is what EHRs have been doing for many people. But what we need to show is actually benefits. And I think, for example, in the systematic review that we've done and meta-analysis, we've been able to show that actually, if done properly and integrating well with existing workflows, it can reduce the time needed. Because, for example, if we think about a workflow where patients don't need to come to the consult room to say what their symptoms are and their history, you can save quite a lot of time. They can pre-fill it in the waiting room. They can pre-fill it at home, take their time to respond fully, and present only to the doctor, for example, the specific and the personalized, so it's a summary that's pertinent to what they need, right? And then the rest in the bottom. It saves time because I would say as a clinician myself, I can only spend, for example, 10, 15 minutes with the patient. I can focus on verifying their needs, really directly answering and looking after their needs, not trying to grasp and find what actually they want beforehand. That saves time. Fits the current workflow, doesn't change much. You still do what you need, but it reduces the time spent on unnecessary stuff so that it gives back time, because that's what we need, right, in clinical practice. So maybe that doing a human-centered design approach really start with the unmet need and have technology be pulled by the unmet need, not technology pushing for a need to be there to implement it in practice.
Yeah, great. Yeah. So it's about fulfilling the unmet needs. Okay, I think we still have questions and we are about running out of time. Okay. This is from Iqbal. Okay. Assess readiness of community, particularly elderly groups or health workers, to use digital information system, and in the context of rural area, it seems impossible. Yeah, this is the challenge in Indonesia with the very complex geographical situations. Okay, maybe you can respond to that question.
Yeah. I'll answer this reflecting on experience the George Institute have with Smart Health, where we've scaled this to over 100 villages in Malang, in Indonesia. So in that setting, for example, we work with community health workers, so cadres, right, in Indonesia, many of them also elderly. But I think what we need to keep in mind in Indonesia is we have a high penetration rate of mobile technologies. So the smartphone, and they can be quite cheap these days, is quite abundant. And we increasingly have very good connectivity for basic stuff. And it is possible to design systems where they only synchronize when you have good reception and store otherwise in their cache, let's say, or on their onboard memory before that. And again, use edge computing to deliver some of the decision support functionalities without needing internet. So I think we shouldn't underestimate the elderly, some would say, or people in the regional areas, their capacity to be able to leverage digital health. I certainly agree that it's not for everyone. And there are patients that I see, for example, who I know can't even make a phone call, for example, right? So with those patients, certainly it's the carers and the families that we need to support using the technologies on their behalf. But for the most part, one cost-efficient way, certainly, to do it is to deliver it through community health workers, I think of which we have 1 million of them in Indonesia. They have phones, fund them to get good or to have data. I think cellular data is one barrier, right? Often it's not the phone itself, but it's the data cost, right? That can be quite costly for individuals. So fund them to have data, develop softwares or implement softwares that work with existing smartphones. It need not be flashy again. I always see digital health, sometimes the settings like Indonesia is the simplest ones, but ones that improve evidence-based management, right? Evidence-based recommendations. And that is possible. And we've shown it possible. And for example, if I recall correctly the numbers, we were able to show across a 5 or 10-year follow-up in Malang, we are able to improve mortality, a very hard outcome significantly, and add a few years to the life expectancy of people living in villages where the community health workers were provided with digital health tools. So these are not really in a hospital setting, these are in a community setting with existing mobile phones where we fund them to have data and provide softwares which work without even internet for the most part. So I think those workarounds need to be done, and it is possible. Though. I think if any, I think it's the right time for Indonesia to do more of that, to go ahead, right? Because we just don't have enough health professionals.
Okay. I think that is all the questions, right? Yeah, Dr. Siddiq, there's no more questions? No more. Yeah, I think that no more question is relevant to you. I saw there are some, but maybe for other presenters, but they already leave the seminar, leave the Zoom. Okay, thank you, Anthony. I think yeah, talking about AI is always interesting and always challenging, but yeah, just like Dr. Ivo said in the morning, that how it is, the molecular test is exactly high cost and also related with technical difficulty, but we have to move on. And so that's with AI. Because AI is the future, of course, we will not live without AI anymore. We use AI in everything. We use ChatGPTs almost in every maybe academics activity now. And thank you for that. Yeah, it's very hot issues in AI. And to honor your contribution, we proudly present you this e-certificate for Anthony Paulo Senjaya, MD, PhD, SM, MSc. And thank you for your valuable contribution in this seminar, and good luck for your research endeavors. Okay.
Thank you. It's my pleasure. Hope it's
Okay.
helpful, and feel free to reach out.
Yes, and
I'll try my best to respond.
yes, and yeah, Dr. Anthony is willing to provide response in the Menti, or also you already send, you provide your email address, right?
Yeah, I provide. I'll send it in the chat. I'll send it in the
Yes.
chat.
Okay, and hopefully that there will come a lot of chances or to collaborate and networking in other research areas, and we will try to collaborate more and more. And this is one of the aims of this webinar, that provide collaboration and networking with other diasporas around the world. And this is the closing. Thank you to all of our speakers for their all excellent presentations, and to our audience for the active participants, and keep staying in the Zoom meeting for more than 3 hours. This is superb, of course. And it's like I will sum up briefly that Dr. Ivo presented about the importance of molecular test or detection for cancer, while Dr. Eva reminds us about occupational asthma, and Dr. Anthony inform us about how can we use AI or applications for diagnosis and or for helping either the physician and also the patients to provide better treatment. So all of the speakers has highlight the importance of doing their own fields and what technology enhancements that can be done to improve the diagnosis and therapy for better outcome for our patient, and of course for our population everywhere in the world. And to end this seminar, this concludes our seminar today. So I will now hand over to our Master of Ceremony, Mbak Andalusi, to lead the closing ceremony. Thank you.
Thank you, Mrs. Yuyun, for leading a very interactive discussion. And thank you for the speakers for a very interesting presentation. Ladies and gentlemen, this is the end of our agenda for today. I'm Andalusi Arini. On behalf of the committee, I would like to say thank you very much to our speakers, moderator, and all participants. See you in the next event. Allow me to close this event with pantun. Burung cantik, burung cendrawasih. Tertangkap mata ada di dahan. Cukup sekian, terima kasih. Mohon maaf atas kesalahan. Wassalamualaikum warahmatullahi wabarakatuh.
Cakep. Hari ini pantunnya topiknya burung-burungan. Semua. Burung dara, burung
Terima
angsa.
kasih Bu Yuyun semuanya.
Terima kasih semuanya. Thank you, Anthony. See you.
you.
Okay. And everyone. Yeah.
Terima kasih Mbak Desi, Pak Antoni, terima kasih Bapak Ibu.
Thanks, everyone. Have a good day.
Yes. Nunggu sampai pesertanya keluar semua.
Alhamdulillah.
Alhamdulillah.
Streamingnya di end.
Apanya? Streamingnya ya?
Mm.
Streaming sama record.